serves as chair. Ron has psoriasis and works with NPF staff, healthcare providers, and other people living with psoriatic disease on local, state, and federal initiatives. A successful business leader and father, he is married with 2 daughters and lives in Windermere, Florida. Leah Howard, JD, joined the National Psoriasis Foundation in 2012. She was appointed to the role of interim president and CEO in January. She previously served as NPF Chief Operating Officer, providing the strategic direction, vision, and leadership to the foundation, mission-related functions of government relations and advocacy, marketing, and communications, and patient services. Prior to this role, Leah directed the Advocacy and Government Relations Department. Leah has led a number of major initiatives for the NPF, including development of the current strategic plan, leading the planning for the 2016 FDA patient-focused drug development meeting, engagement with value assessors, and the NPF annual payer roundtable series. Welcome to you both, and thank you for what you guys do.
I thank you for that. Thank you, Jennifer. So I'm up, I would imagine, right? I'm up first, so thank you for that great introduction. You know, I was thinking back as I was organizing my thoughts this morning on what to say at this welcome. I apologize, there's a noisy printer going on in the background because someone is printing in my house. I thought back to you know, the early days before even joining the board. Back when I had psoriasis and psoriatic arthritis and looking for help and reached out and found the National Psoriasis Foundation. Worked hard as a volunteer, was later asked to join the board, and now, you know, as of last July, the chairman of the board. And so I just think it's ironic, you know, being in the psoriatic disease community, and then being chairman, being exactly where you folks are, you know, in the community, working hard, volunteering, etc. And then, you know, it's such an honor to be here today. And, you know, being on the board is, you know, sort of having a firsthand look at how things are done, how things are run. I just want everybody to know that this community is very, very well represented, a great staff, hardworking staff, and of course, a hardworking board. And we all love what we do. And just wanted to say, you know, I just wanted to sort of say that before I started my welcome remarks. So moving on behalf of the NPF board of directors and including some of my colleagues who are joining us today, I want to say welcome to the first NPF Community Conference of 2022. Our theme of this conference is Healthier Together, Celebrating Our Differences. And isn't that a great theme? We know that individuals of all ages and all races and all ethnicities, really all backgrounds, are impacted by psoriatic disease. I'm so glad we're gathering here today to learn more about how we can bridge those differences and support one another. As we kick things off, I wanted to reflect just for a moment on the NPF at the start of 22, because it's such an incredibly exciting time for the organization. Can you believe that we're already halfway through our current 5-year strategic plan? Hopefully you've gotten to see some of the exciting announcements that have come out in recent months, including back in August, the NPF was awarded a significant grant from the Centers for Disease Control and Prevention. In September, NPF announced funding of a multi-center clinical trial aimed at reducing cardiovascular risk for the next phase of psoriasis prevention initiative, what we call PPI. And in December, NPF announced a partnership with the National Institutes of Health and others to identify and map key biological pathways that drive immune-mediated and autoimmune diseases. I'm happy to say that the board believes the future is incredibly bright for this organization. As we start the new year, we're also starting a new chapter at the NPF. As many of you know, our CEO of 14 years, Randy Bronick, retired at the end of December. Upon Randy's retirement, and at the board's request, Leah Howard moved into the role of interim president and CEO. Some of you may know Leah, who has been with the NPF for the last 10 years, most recently as a COO, Chief Operating Officer. Although Leah has interim in front of her name, she's really jumped in with the team to begin to build the NPF of the future, which I like to refer to as NPF 2.0. So big thanks to Leah for all of her great leadership. Before I turn it over to her, I want to conclude my welcome by expressing how much we appreciate you joining us today. It's great to see all of you, and thank you for joining us. Over to Leah.
Thanks, Ron, for that introduction. And thank you, Jen, for yours as well. Jen's right. We've had an opportunity to work together a ton. In fact, I feel like I can say I knew you before you were a nurse. So, I mean, that's years. And you're right. I've gotten to be part of your team for Capitol Hill Day and done videos with you. So I'm thrilled. I share Jane's appreciation for your willingness to do MC duties here today. As Ron said, there's definitely a lot going on at the foundation, and we certainly have a lot of work to do, but we are incredibly lucky to have an amazing staff, an amazing group of volunteers that we're doing that work with every day. So I too welcome you, and I just want to say how excited I am about today's theme. When I was working with the staff on preparing for today's conference, they shared with me that we have individuals registered today from 18 different countries and the United States. So just amazing kind of the breadth of perspectives that are here today and the breadth of backgrounds. And so I definitely think we've captured the theme of differences and diversity here this afternoon. As Ron noted, we are beginning to write a new chapter for the NPF. And I have just been so honored to get to work with many of you and the rest of our community over the last 10 years as we've done amazing work. And as we look to the future, that's the work that we're really going to be building on. So please engage with us. Please, participate in whatever way feels right for you. But we would love to bring you with us and have you be a key partner and contributor to what we're going to be building in NPF 2.0, as Ron mentioned. We know that despite all of the scientific advancements and discovery and progress in our space in recent years, there's many individuals that live with psoriasis and psoriatic arthritis that are still struggling. And we know that despite the new therapies that have come to market and the progress that we've made, many individuals find that their disease is really continuing to impact their life on a day-to-day basis. We know others are suffering from comorbidities and challenges with those. And we all want a cure, right? Everyone that lives with psoriasis, myself included, would like to see a cure for our disease. So that's really what the work that the NPF is about every day. Our mission is to drive efforts toward a cure and to improve the health outcomes for those of us living with psoriasis and psoriatic arthritis. So as we engage in today's discussion and beyond, please know that the NPF is your resource. We are here to meet you wherever you are in your journey and kind of take that next step to better health for you. I'll be here listening and contributing throughout the conference. You'll see me in the chat, popping in some comments. If there's things you want to connect on, feel free to message me here today or to reach out anytime. I'm really here to serve you. So know that that door is always open, and I welcome contacts from each of you and others in our community. So it's my privilege to turn it back to Jane and to get today's great content kicked off.
Thank you, Leah. So we're going to kick it off with our about women's and men's health. I'm going to go ahead and introduce our two speakers. We have Dr. Jenny Murase, an associate clinical professor of dermatology at the University of California, San Francisco, also known as UCSF, and the director of medical consultative dermatology at the Palo Alto Foundation Medical Group in Mountain View, California. Dr. Murase has a special interest in women's health and is currently the co-editor-in-chief of the International Journal of Women's Dermatology, the secretary and governance council chair of the Women's Dermatologic Society, and is a founding member of the American Academy of Dermatology's Women's Health Resource Group. Dr. Evan Rieder is an assistant professor of dermatology at Ronald O. Perlman Department of Dermatology at NYU Grossman School of Medicine at NYU Langone Health, where he treats a wide variety of skin and nail diseases, which includes psoriasis, hyperpigmentation, skin tumors, and more. Dr. Rieder is one of the few physicians in the US who is board certified psychiatric and dermatology, which offers a unique perspective on the management and quality of life associated with skin diseases such as psoriasis. Dr. Rieder, given their unique specialties, Dr. Morassi and Dr. Rieder are the perfect speakers to address about women's and men's health. Thank you both for joining us today.
Dr. Morassi, I'll go ahead and stop sharing if you'd like to share your screen then.
Certainly. So, thank you so much for having me today. I have to say that I became interested in the health of women's health and psoriasis about 20 years ago, and the National Psoriasis Foundation was one of the first entities to support my interest in my research. And so you're kind of, what I'll be talking about today is really reflective of the fact that the National Psoriasis Foundation really does support the physicians caring for patients with psoriasis, as well as the patients with psoriasis, so extremely well. And so I'm very honored to be able to speak today. Much of the information that I will be sharing is available for patients that are listening that want to reflect on what I've said and access the information on this website, which is the Women's Derm. I'm the co-editor-in-chief of the International Journal of Women's Dermatology. And so the website is wdsijwd.org. And if they click on Women's Health Highlight, or alternatively, you can click on Patient Page. If you scroll down a bit, you'll be able to see article Clinical Considerations for the Management of Psoriasis in Women. And there's an accompanying patient page here that was designed for patients. And so that's a resource for you if you want to access the information. So let me pull up my slides here. And so today I'm going to be reviewing the content of that article. And so this includes the psychologic impact of psoriasis in women. I'll be talking about hormonal influence, including menarche, when women first get their periods, as well as menopause. I'll be talking about some family planning consideration in both men and women, the impact of treatment options, particularly in cases of pregnancy, and I'll also be talking about breastfeeding considerations. These are my disclosures. I do non-branded talks for both Regeneron and UCB. Particularly for UCB, I talk about psoriasis and pregnancy, as I said, non-branded, so I don't talk about treatment specifically. I've been on advisory boards for a variety of companies, and I've also done dermatologic consulting as well. So when the impact on overall mental health is something that, even being someone that had studied this for years and years and years, I really didn't appreciate until I was interacting with a few patients regarding something that I had to do for, it was a podcast regarding women's health and psoriasis. And I had to approach patients that had been pregnant under my care with psoriasis. And so I thought, okay, well, this is going to be very easy because I've cared for many women that had been pregnant with psoriasis, and they expressed how grateful they were that they were able to have the families that they wanted, because they were nervous about going on treatment before they had come into my office, and I reviewed different options with them. But I found that it was actually quite difficult to find patients that were willing to participate in this podcast. And it really wasn't until that moment that I really understood how severely the psoriasis was impacting my patients in terms of sort of the anticipating rejection or feeling being flawed or sensitive to the opinions of others, and the secretiveness. Some of my patients said that they couldn't risk, even if their voice was modified and their face was not being shown, because there was only 5 people in their life that knew that they had psoriasis, and I was one of them. And so I think that being a practitioner who cares for patients with psoriasis, that was very eye-opening to me, because that was after 15 years of considering myself someone that specialized in psoriasis, and particularly in women's health. I didn't really appreciate how much it does affect overall emotional being, and this is true more so in women than in men, although of course it affects both significantly. Now, psoriasis may fluctuate with hormonal changes throughout a woman's lifetime. There have been reports of worsening during menstruation, when the levels of estrogen are higher later in the period, as well as if the estrogen levels are higher during pregnancy, the psoriasis tends to improve. when estrogen levels drop, such as during menopause or right as the baby's born, the psoriasis can worsen. And that's due to the effect of estrogen as what we call a nuclear receptor. There are many therapies that we have for psoriasis, different vitamin D derivatives or vitamin A derivatives or corticosteroid therapies that are also nuclear receptors. So estrogen is a similar kind of hormone, has a positive effect on psoriasis at higher levels. So really, I emphasize when I'm speaking to physicians that family planning really needs to be addressed in all women of reproductive potential, because 50% of the pregnancies in the United States are actually not planned with any kind of healthcare professional, speaking with them in advance of getting pregnant. And it is actually 20% of the time that subspecialists such as dermatologists are approached before a woman becomes pregnant. So 80% of the time we don't talk about it, the pregnancy in advance with the patient. So it's really important when we place patients on therapy that they're on therapy, that should they become pregnant, they won't have issues with their pregnancy, because the development of major organs third week after conception. So it's very early on that organs are being formed. And so most women discover that they're pregnant about 2 to 5 weeks after conception. And this is already when major organs are being developed. So now we're going to talk about psoriasis treatments. So first of all, in terms of family planning for male fertility, there haven't been any dermatologic medications that have been shown to result in increased birth defects with men taking the therapy. Some have a reversible effect on spermatogenesis and fertility, but it's not a question of birth defects for men specifically. So methotrexate there have been cases reported of severe oligospermia, which means a low sperm count, and that is reversible. So prior to trying to conceive as a couple, a man with psoriasis would want to discontinue about 3 months prior to conception. Cyclosporin does not have any adverse effects that have been reported in humans, but there were animal models that showed possible occult sperm damage. So for that reason, we do also recommend, potentially discontinuing 3 months prior to conception just to maximize the sperm count. Now, interestingly, the TNF alpha, which is tumor necrosis factor alpha, many people that are on this this webcast may recognize this from the anti-TNF therapies that we use for psoriasis. Medicines such as etanercept or adalimumab or infliximab, for example. But TNF alpha doesn't inhibit spermatogenesis. So if you have an anti-TNF alpha, like the medicines that I just mentioned, such as infliximab, there actually have been in vitro showing a positive effect on sperm function. In terms of other oral treatment for psoriasis, there is the oral medicine, acitretin, which is a vitamin A medicine. This is not an immunosuppressive. We use the vitamin A derivative called isotretinoin for acne. We use acitretin, which is a vitamin A derivative. They're kind of like sister medicines we use for psoriasis patients. And for isotretinoin, there has been, at high doses, it has inhibited spermatogenesis. For acitretin, human studies have found that it does not affect spermatogenesis, but this has been studied more in isotretinoins. This is another one where you may consider recommending stopping 3 months prior to conception. Now, I first became interested in the topic of psoriasis in pregnancy, as I said, 20 years ago when the National Psoriasis Foundation supported my research. And I looked at 65 women who became pregnant, and I followed their psoriasis during their pregnancy as well as postpartum. And I found that about 50% reported improvement during pregnancy. And then there was about 2/3 that would worsen following the pregnancy. And there were a few interesting points to what I found when I looked at the psoriasis. So this table, I want to make sure that everybody understands how the figure is formatted. So if you reach the far right dotted line, that is a patient that got 100% improved during the course of their pregnancy, from early in the first trimester to late third trimester. If you reach the dotted line on the left, that means that your psoriasis doubled during the course of your pregnancy. So you can see that, as I said, 50% improved, but the improvement was really quite dramatic, with an average of 80% of the body surface area clearing during the course of pregnancy. So the pregnancy itself can be therapeutic for the psoriasis. It can improve the psoriasis substantially. Interestingly, the flare postpartum was really a return to baseline psoriasis, usually within 6 weeks postpartum. Now, in terms of therapies, the topical corticosteroids have been the most studied medicine that we have, a topical medicine in dermatology. There's something called the Cochrane review, where they look very, very carefully at data and really, really thoroughly look to make sure that medications are safe. And this has been studied in tens of thousands of people to give us reassurance that topical corticosteroids are safe during pregnancy. If possible, based on another study that was done by Dr. Chi, who it was in London at Oxford at the time that he did this study, he found that if you used over 300 grams, usually tubes come in it's usually a 60-gram tube. So if you dispense over 300 grams, which would be 5 of those tubes, that there was a potential slight increase for low birth weight. Now that might be because the underlying condition was so involved and so severe. A lot of these patients did have atopic dermatitis, and they were not psoriasis patients that were studied because it was just looking at topical corticosteroid use in general. So it's unclear if this is because they required so much topical corticosteroid that's why there was a potential for low birth weight. But I try to keep the amount that I dispense to be less than 5 tubes during the course of pregnancy as a result of this. But there was no increase in, oral facial cleft, some kind of malformation or any issues with delivery or fetal death or Epicardia. There was no adverse effects that were reported in his study. Light therapy is generally considered the safest form of therapy for a pregnant woman. When the light hits the skin, it does cause some vitamins to break down, such as folic acid. And so PUVA, which is the psoralen pills that make you more sensitive to the light, plus UVA, ultraviolet A light, does decrease folic acid levels. And there was one report showing that with narrowband UVB, which is by far and away the most common light treatment we have nowadays, that folate levels did decrease by about 2 points. No patients received, and this was after on an average 42 treatments of light, no patients received or developed folate deficiency levels in this particular study. But my patients, when I place them on light therapy and they are women of childbearing age, I always have them take a prenatal vitamin that has plenty of folic acid in it every day in order to maintain their folic acid stores. Cyclosporin used to be the systemic, full body treatment of choice if light didn't work for a pregnant patient, because it was studied so thoroughly in the transplant population, showing that there wasn't any increased risk of malformation. There was potentially a little bit of growth restriction, but that's very difficult to assess because of the fact that these patients taking the cyclosporin were so sick. And they actually followed cohorts of children until the children were 2 or 3 years of age just to make sure that there was no neurodevelopmental or effects in their immune system or any kidney defects. So they really thoroughly studied to make sure cyclosporin was safe. Another oral medicine for psoriasis, apremilast, really in animal studies, there was an increase in abortions and fetal death. So I tend not to recommend this therapy because of the fact we don't really have a lot of data to support its use in humans during pregnancy, and the animal data concern me. So I want to talk a little bit about the biologic medications because that's something that comes up the most in terms of questions. If a woman's psoriasis is not controlled during pregnancy, are the biologic medications safe? And there really is an increasing amount of safety data to show that they are safe. I want to explain why. So you can see on this curve, there's two lines. There's the blue line, and then there's the red line. Okay, but I want you to focus on the blue line. So before, as a baby is developing and it's 10 weeks or 20 weeks old, it can't live outside the mother's body. So there really is very little antibody that's being that's crossing over the placenta to the baby, because there's no need for it. The baby's not going to be outside the mother's body trying to fend for itself, right? The time that the baby does need antibodies is right before the baby is going to be delivered. And that's when it needs to have its immune system nice and strong to go out into the world. So antibodies don't cross the placenta, being transported across the placenta until about the early second, really more mid or late second trimester. Most of it occurs during the third trimester, and you can see this is called an exponential curve when it goes shooting up just prior to delivery. Now, the way that the body gets it to shoot up is it has these what are called villi, which are kind of like little fingers on the placenta, and it grabs the neonatal FC receptor and it brings it over, and it brings tons and tons of antibody over to the baby. And these antibodies from the mother are present until up to about 7 months of age for the baby, okay? And so medicines like infliximab or adalimumab or secukinumab, for example, these are IgG antibodies. So they're really, really big, and you have to grab them with this FC receptor to bring them over to the baby. Now, one of the medicines for psoriasis, etanercept, is what we call a fusion protein. So this doesn't need this FC receptor to grab it and bring it across, okay? It's just going to cross what we call by simple diffusion. That means just sort of crossing freely. So if you look at how much etanercept is in the baby when the baby is born to a mother on etanercept, it's only about 4 to 7% of the mother's levels, whereas antibodies such as infliximab or adalimumab, they're at 160% of the mother's levels, or 150%, because they've been brought across. So the really key thing is that these biologic medicines are not really present when the baby's organs are forming, which is the 10 weeks, basically the first trimester, beginning of the second. But there will be in higher levels at the very end of the pregnancy. And so there was a case of an infant death with a mother that was on infliximab every 8 weeks. She actually had Crohn's disease, which is for the GI tract. It's an inflammatory disease. She didn't have psoriasis. Her baby was healthy. They were living in an area of England that has tuberculosis as an issue. So they give the Bcg vaccine, which we really don't give very often in the United States, but they do give that in this area in England, endemic for BCG, or sorry, endemic for tuberculosis, excuse me. And the Bcg vaccine is the vaccine for tuberculosis. So the infant was healthy until the infant received this vaccine at the age of 3 months, and then died a month and a half later from what we call disseminated, meaning all over the body, BCG. So the baby, if a baby is born to a mother that is on therapies that cross the placenta, they will be a bit immunosuppressed. So their immune system will be down that first approximately 7 months of life. there is a medicine called Certalizumab. This is also an anti-TNF therapy. This doesn't have the FC region of the antibody. So that means the placenta can't grab onto it and bring it across the placenta to the baby. So when they measure babies that are to mothers that are on this particular therapy, the baby doesn't get any of this medicine, and so there's no immunosuppression. So this is a picture of a condition that is a little bit unique to pregnancy. It's called pustular psoriasis of pregnancy, where you get these kind of plaques that have pustules on them. This is a different thing than just having psoriasis and trying to control your psoriasis. A lot of people who have this don't have a personal history of psoriasis, and it tends to occur late in the pregnancy, about the third trimester. If you ever developed, pustules, if you have psoriasis and you're pregnant, we have to check a calcium level. That's very important, because with this condition, you can get low calcium levels, and this can result in seizures. So we need to be always looking at patients that are pregnant and looking for these pustules and making sure we're ordering appropriate labs. It can occur in future pregnancies if someone develops this during pregnancy. And even if people are treated, sometimes, it's a variable in terms of how the pregnancy goes. So it's a particularly important condition for us to monitor. But as I said, this is not something that we consider to be classic for a patient with psoriasis. This is kind of a different thing, and it usually occurs in patients who don't have history of psoriasis. And so, as I alluded to earlier, people will improve during pregnancy, which is, you see how they started out at a certain body surface area, and their second trimester and third trimester, it dropped. And then once the baby is born, number 4 represents 6 weeks postpartum, and number 5 represents 3 months postpartum. They basically return to their baseline psoriasis. And so for that reason, if someone has been clear because of their psoriasis during their pregnancy, I always make sure that I have an office visit right after they're going to deliver, after, so that if the psoriasis does come back, we are ready for it, and we've started treatment, or we are going to anticipate starting treatment very soon, so that they don't have a flare. Because what can happen if a woman would like to be able to breastfeed their infant is the process of breastfeeding with the infant's mouth on the nipple. It's very irritating to the nipple area. We call it Kebnerizing, after Dr. Kebner, who named this, where if skin is traumatized, if there's trauma to the skin, you fall off a treadmill and you scrape your leg, psoriasis can form in that area of trauma. Similarly, the nipple area can also Kebnerize, and there can be psoriasis that forms due to the trauma from the breastfeeding, because it's very irritating. They estimate in the first week that 97% of women feel pain in the nipple area from breastfeeding. So it's very common to experience pain. And so lactation consultants that specialize in how to get the baby's mouth around the nipple to limit trauma, it's very important to look in advance of the pregnancy, or I should say the delivery. I mean, in advance of the delivery, look into who could help with latch and who is a good lactation consultant in the area, and establish kind of care with them, so that if you do need them a week or 2 after delivery, you have that consultant to talk to. There are a few treatments to avoid during lactation. Most of them actually, such as all the biologic treatments, you can take without any difficulty. The ones to avoid are the acitretin, which was the vitamin A derivative that I mentioned, methotrexate, and then also apremilast. Really, all the others are safe for a breastfeeding woman. Light and topical treatments are very common. We do want to avoid just the class 1 cortisones. There's 7 classes of steroids. 1 is the strongest and 7 is the weakest. Examples of class 1 would include things like diproline or clobetasol. So we try to avoid those on the nipples, but really all the other topical therapies are safe. It's really important that that you're aware that topical cortisones, even if they're mid potency, like they're like hydrocortisone, like a 7, or something like mometazone or triamcinolone, even these lower cortisones. This is a picture on the right of a woman that was using a mid potency cortisone just twice a day for 2 weeks. Because her skin was rapidly expanding and contracting during the day because of her breastfeeding, she developed stretch marks that were quite severe, and thinning of the skin that was quite severe on the breast. So it's really important to be aware of how much cortisone you're using on the breast tissue, because it does expand and contract constantly from the breast milk, and that can increase the chances of stretch marks, which are permanent. So in terms of immunosuppression during lactation, I alluded to the fact that the biologics are safe. The IgG, which is the immunoglobulins that a lot of biologics are, they transfer into milk really significantly only the first 4 days postpartum. Otherwise, it's another antibody called IgA, and that's irrelevant to the biologics. And also, the biologics are very fragile. If you take them by mouth, stomach acid destroys them. That's why they have to be injected. So, if the baby, was exposed somehow to a bit of the biologic, the stomach is going to destroy it, stomach acid. And in particular, Certalizumab, the one that I spoke about earlier, has studied this, and I'll go over that in detail. Now, interestingly, when we looked at different doctors in terms of their knowledge about safety during lactation, there was a very strong number, or I should say, a large number of physicians that, when we asked, should women not be on an anti-TNF treatment because they're breastfeeding, were a lot that strongly agreed and somewhat agreed, even though the data really didn't indicate this. I think that this is an area that, as a physician who teaches dermatologists, I try to make sure that they're aware of the actual data so that they're making good recommendations to patients and really accurately describing safety issues. Because this study here, the CRADLE study, it was called, looked at Certalizumab specifically in breast milk, and they found that there really wasn't any detectable level. So it really shouldn't be that a recommendation is made to stop during breastfeeding itself. Is very, very helpful for the overall health of the infant. For final take-home points for the first portion of this, which is the women's health portion, I think it's important to realize that 50% of pregnancies in the United States are not planned with a care provider. So, we really need to make sure as doctors that we're prescribing therapies that are safe should a woman become pregnant if they're in childbearing age, but also, you want to be aware of the risks of your medicine should you become pregnant. For example, being on light therapy and taking a prenatal vitamin just in case if you're a woman of childbearing age would be an example of that. And then also the biologic medications do have mounting safety data showing safety of the anti-TNF class in particular in pregnancy and breastfeeding, but also the others seem to be have an increasing amount of safety data as well. We have the most data for the anti-TNF class, and in particular the Certalizumab medication. So thank you for your attention. I am going to take questions, I believe, at the end. And so what I will do is I will stop my sharing. Actually, I don't know how to do that.
Up at the top of your screen, Dr. Murase.
I see it now.
Great.
Yep. Okay, I see it now. Okay.
Thank you. Dr. Rieder, are you ready to share your screen?
I am ready, and hopefully you can hear me. Let's get
Coming in great.
Okay, great. So I'm glad that Dr. Murase had a little bit of struggle getting unsharing her screen, because this is always where I screw things up as well. So I won't be alone in that. Okay, let me share a screen. Desktop. Okay, can we see the desktop?
Yes.
Great. Okay. Okay, it worked. Okay. All right. So thank you so much to the National Psoriasis Foundation for having me today. I'm honored to be able to speak along with Dr. Murase, who I actually haven't met in person, but I read a lot of your papers. And let me know if my connection goes out, but anytime the National Psoriasis Foundation asks me to do something, I do it because I think it's an organization with an amazing mission and you guys do so much important work. So again, a really big honor for me to be able to speak today about a topic which I think is interesting and maybe not spoken enough about, which is men's health and psoriasis. So this is the basic outline, and I will try to stay on time. We're going to be talking about male behavior, and I think it'll be clear about what I mean when I start talking about that. Some differences between men's and women's skin and how that may affect what we're doing with psoriasis and some of our medications. And then the bulk of it is going to be about psoriasis in men versus women, if there are any big differences that we're seeing, particularly evidence-based differences that we see in our male population. And then if there's time for it, I'm going to be going over some practical tips that I talk to my patients about, especially my male patients who are a different category of patients in general. All right, so here's my disclosures. These are all consultancies that I have done over the last couple of years. And I think the only one that maybe I do some consulting, just looking at data safety with UCB and BMS, looking at some of the newer biologic drugs for psoriasis. And then I do work with an organization called Happify Health, which has a partnership with the National Psoriasis Foundation. And if you are listening to this talk and you're not a member of COPA for psoriasis, I do consulting for them, but I think it's a wonderful application where I've been able to interact with a lot of people living with psoriasis, and there's other dermatologists who interact with the community. We post information, we post studies, and we also take questions. And I think it's been really nice and a supportive community for doctors and people living with psoriasis alike. And some of our doctors are living with psoriasis as well. So let's get into it. So we'll talk a little bit about male behavior. All right. And so, and I will preface this by saying even the terms men and women and male and female are sort of fluid these days with gender norms of the past being things of the past, and gender fluidity and trans culture and cis and trans people becoming more in the mainstream and feeling more comfortable with themselves. We're really talking about sort of heteronormative cisgender male behavior here, okay, to make a sweeping generalization, but there's a huge spectrum of people who are living with psoriasis who may not fall into that, but we're looking at where the evidence has led us so far. Okay, so male behavior. So I like to think about heteronormative male as sort of simple animals. And I can say that as I am one of those people. We tend to think with fear, and we tend to think with a fight or flight response. Men are not so good about taking care of themselves. We are not the best about going to the doctor for preventative visits, whether that's going to the general practitioner, whether that's if we have a condition like psoriasis, getting that checked out, or getting our skin cancer screenings. We just don't do that as regularly as females do. Because of that, we tend to see skin cancers having in men at a much higher rate of severity. Men are also unlikely to be going in for anti-aging treatments, so maybe coming in to see a dermatologist or someone who's practicing in aesthetics at a different time in their life, maybe when it's too late to begin an aesthetic journey. And then when thinking about things like inflammatory conditions of the skin, men are known to have inflammatory conditions like psoriasis that present at a more severe time in their life and have more severe psoriasis in general, because I think part of it is because we just don't take care of ourselves. I put this picture of Tom Brady on the side here. He's sort of like one of the icons of male sports figures. And one of the things that he was talking about for years was that he stayed in such good shape because his solution to the fountain of youth was to drink a lot of water. And I think a lot of men think that it's very simple interventions like this that can get you to the next step and to keep you safe and healthy. And obviously Tom Brady was doing much more than that, has a very rigorous diet and a very rigorous workout regimen, and probably blessed with incredible genes as well. So things are not always that simple. Okay, so men get their information sources from different places as well than the rest of the world does. So I put this picture on the side showing the guy sort of hidden in the background, in the dark room, looking at online for his information sources. And this is actually evidence-based. When men were surveyed and women were surveyed, the guys were more likely to get their information online and from things like social media. We know with the contemporary world being what it is today, there's a lot of misinformation that comes from social media. There's also a lot of amazing information that comes from social media, but a lot of people who are not experts in their area have a lot of difficulty sorting out the real from the fake. It seems like this is where men are getting the most of their information. Men also get information from family and friends, both of which can be good sources of information and be bad sources of information. Again, we look no further than what's going on in contemporary societies, specifically related to the COVID pandemic and with current politics, to know that there's a lot of good information out there and there's a lot of not so good information. And people are pretty heated about both sides of it. And then finally, from dermatologists, thinking about this is to me, it's kind of scary because people are sometimes come into my office and have a preconceived notion about what they want their treatment to be, whether they're coming in for psoriasis or acne or something else. And they have said they've tried everything in the past and nothing has worked. And then when you start getting into question and answer, people haven't really tried anything except for the over-the-counter treatments. And we're really in the golden age of psoriasis treatments now, where things that are prescribed by dermatologists or people practicing in the field of dermatology, some of our nurses and physician assistant colleagues, these are medications that can really get people's quality of life improved to a substantial amount. And then for a lot of people, we can get their skin 90 to 100% clear. So we have to take things with a grain of salt. And I think if you're a man or you're living with a man who has psoriasis or have a friend or family member with psoriasis, I think we have to think about where they're getting their information and what their sort of preconceived notions about treatment are to begin with. Okay, so with that being said, let's talk about some basic differences between men and women's skin, which I think is helpful to think about just to conceptually to know how the skin is going to react differently to different things in terms of what we're putting on it. So in general, men tend to have thicker skin than women, 20 to 25% thickness in male skin versus increased thickness in male skin versus women's skin. And men tend to have greater musculature, especially in the face, okay? And men tend to have oilier skin. So we have increased sebum production for our sebaceous glands. It makes the skin oilier, it makes it more shiny, it makes it less to have like that matte appearance to it. And that's something that makes a lot of my patient population and myself a little bit upset when we looked in the mirror. That oiliness plays a role in what products that we like to put on our skin. And then collagen. Now, we all lose 1% of our collagen a year on average, starting at age 30. But in men, there's an increased collagen loss with a slow, gradual decline over time, as opposed to women's skin, which happens, the collagen decline happens rapidly at menopause. And this is, again, this might seem like a non sequitur, but I think it's important because when you think about the products that people are going to like putting on their skin or to dislike putting on their skin, you have to think about men's versus women's skin. I think you also need to think about male behavior in general. Most men were not growing up wearing sunscreen. Most men grew up not wearing makeup, again, although things have changed in contemporary times. But in general, I think those things hold true. And then there's certain sensorial things that men are looking for when they look for their products. Men like things that feel like they're working. They may like things that smell good, and fragrances can sometimes be irritating to skin, but sometimes this feeling like the pores are opening or there's something fresh happening on the skin is something that men respond to. Because men's skin tends to be oilier, we don't like things that leave a sheen on the skin. We like things that absorb. We like things that give a mattified finish. And I think a lot of times when you're thinking about psoriasis products, especially the creams and the oils and ointments, I tend to stay away from a lot of them on the face, especially in men, because they're just not going to use them. It's not going to be cosmetically elegant, and they're not going to be things that men are going to want to do in the first place. So if you finally, if you're at the point where you're a guy and you have psoriasis and you're actually willing to use a product on your face, it doesn't feel right, your dermatologist may have lost you from the first moment. So those are things to think about. And because I sort of talked about that, the differential effects of psoriasis products in the skin is something that I think about, because I think about it's a little bit harder to engage a lot of men in their topical therapy. Engaging men in systemic therapies is another ball of wax entirely, and we'll talk a little bit more about that. Okay, and this is going to be the bulk of what I talk about. So the evidence-based differences that we see between psoriasis and how it presents in men and versus how it presents in women. We're going to really be talking about male-specific data that I've been able to parse out through the literature. And it was a kind of a hard task because there isn't a lot written about men in particular, but I think I've gotten some interesting points that we'll be able to talk about today. So this is a little bit of an expansion. We're going to be talking about some of the comorbidities, severity of psoriasis, triggers of psoriasis, sexual dysfunction, which is sort of a hot topic, and then stigma and how these all present in men. Okay, so we know if you're living with psoriasis or you're treating people with psoriasis or you have a family member or friend with psoriasis, we know that psoriasis is a multi-system inflammatory disorder. It's not just the skin, maybe just the skin if it's really mild, but it can be affecting the joints, and it can have affect multiple organ systems in the body, and has lots of comorbidities: obesity, metabolic syndrome, high blood pressure, diabetes, atherosclerosis, cancers, lung and liver disorders, and psychiatric disease have all been associated with psoriasis in the literature previously. I think some of the most interesting data that's come out recently, and we're going to talk about 3 papers really briefly, really high level, looking at men in particular, comes in the area of cardiovascular disease and atherosclerosis. So we're going to sort of dig into them a little bit, and we'll get there in a slide or two. So we know the incidence between men and women for psoriasis is very similar, although it may present earlier in women. And it really affects, we understand that it affects people the same way, at least when you're looking objectively. However, the lived experience of psoriasis tends to be different in men versus women. And I'll talk a little bit about what I mean by that in the coming slides. Getting back to what we said before about male behavior, I sort of assumed that psoriasis was going to be worse in men, knowing what I know about male behavior, our reluctance to use products, our reluctance to go to see the doctor regularly, our reluctance to go for preventive health, and our reluctance to address a problem until it's at the point where we feel like we may lose our lives over it. Okay. But in 2017, we actually had the first evidence that psoriasis actually may be worse in men than it is in women. This came from a Swedish study. It's a register study. And the beautiful thing about looking at studies that come from Scandinavia is that they have these nationalized healthcare plans where everybody has to be enrolled, everybody gets free healthcare, which is amazing. And so everybody with psoriasis gets to be followed, and they have a lot of different databases where it's easier to tease out this data. And they found in this study of over more than 5,000 people that women had lower PASI scores, so they had lower amounts of psoriasis on their skin across ages and across body areas, except for on the head where it was equal. Okay, so this is really the first study to show psoriasis was objectively worse on the skin in men on a population basis. Data like that has been replicated in different populations. There was a Swiss and German registry study of more than 5,000 patients as well, and they found that men were heavier and had worse psoriasis, but women, interestingly, had worse quality of life. Now think about that for a sec. So men had worse psoriasis objectively. So you look at the skin, there's more psoriasis on their skin, but women felt worse about their quality of life than when they had psoriasis. And after they were given 1 year of systemic treatment, some of those people were getting biologics, some of those people were getting older medications like methotrexate. Women did have better improvement on their psoriasis scores and on their disease-related quality of life. Okay, so for me, when I was reading that paper, it asked a lot of questions. Were women better with adherence? And one could surmise that that would be a reasonable thing to expect. Women were more likely to take their medications, and especially what we understand about male behavior, that could be a possibility. But women in general have lower body weight, and they have higher fat indexes than men. And it's possible that when you dose people with the same dosing regimen like you would with a biologic drug, where it's pretty much the same unless you apply for special conditions through your insurance company, maybe women were just getting more absorption because it was better stored in the fat, and they were lower in weight to begin with. So the psoriasis drugs took better effect on their system. It's hard to know, but it really begs some questions to me. This is also replicated in the psoriatic arthritis literature, and they found in women the disease activity, physical disability, functional limitations, depression, and anxiety scores were all higher in women, which means these were all, it's sort of written in a way that's a little bit confusing, but it means that these scores were worse. Okay, so people were feeling worse about their disability. They had worse depression, they had worse anxiety, and they were more functionally limited. However, the quality of life and PASI scores were higher in men. So again, think about that. Men had more psoriasis on their body, but had higher quality of life. And women had all these different metrics that were really limited. And then finally, I want to talk just really briefly about a questionnaire study of Swiss patients living with psoriasis. And then fewer women, despite the results, reported high satisfaction with their therapy. Okay, so I think that this kind of stuff is really, to me, it gets to the point as, are we doing something incorrectly between men and women? Should there be more gender-directed therapies? Should men be on higher dosages? Should women have more comprehensive services, because it doesn't seem like they're being met in the correct ways, and that there seems to be a need that's being unmet right now. But more questions than answers right now, I think, looking at the severity scores between men and women. Now, there's a couple, these are the 3 cardiovascular studies I want to talk about, and this is the first one that came out. And again, this is going to be pretty high level, but I think that these are interesting to think about, particularly because of their impact on men and the way that we should think about men. So this is a little cartoon on the right of the belly. Sometimes it's sort of hard to see what we're talking about. You have the spine here, and you have the front of the belly with the subcutaneous fat. So this is really looking at the fat right underneath the skin, not the visceral fat that we know to be definitively associated with cardiovascular morbidities. This is the abdominal subcutaneous adipose tissue, or something they call ASAT. All right. So, and what they found when they were looking at imaging studies of people with psoriasis is that the ASAT was associated with subclinical cardiac disease in men with psoriasis, but not women. And it's really hard to know exactly what to make of this data. Okay, we know that the visceral abdominal fat seems to be worse and has more associations with cardiovascular disease than the ASAT does. But the association with ASAT is there, but the meaning of this is less clear. So I thought, that's kind of interesting. Maybe there's something going on here with metabolic syndrome, with abdominal fat that is happening in men and not in women, and that we need to be more concerned about thinking about body weight in men. All right. So there was a subsequent study, which is a little bit more compelling, looking at something called the Epicardia adipose tissue volume, or the EATV. I think it sounds silly to say it like that, but the epicardial adipose tissue volume, or the EATV, is the true visceral fat deposit of the heart, and it sits right on the something called the epicardial surface of the myocardium, like the true heart muscle. Okay, and it's contained within the sac that encompasses the heart. This is also the place where the coronary arteries, so that supply the blood circulation to the entire body, and the major vessels are sort of embedded in this fat. Okay, and this is the environment where there's local interaction between the fat and the coronary vessels that surrounds. Okay, so this is, I think, an important thing to think about, and this came from a nice paper. And they found, when they did scans of men's heart, it was the EATV fat was higher in men with psoriasis than those without it. And this is men with psoriasis, but no history of cardiac disease that they knew prior to doing these studies. And there was no difference in seen in women. And I think this is a really important initial study, an imaging study that really indicates to us that this EATV fat may be an early identifier of people who are at increased risk for cardiovascular events. So just to take a step back again, people with more fat around their heart with psoriasis without any known history of cardiovascular disease may be at increased risk of having cardiac events. And that's something that also contributes toward the data looking at comorbidities of psoriasis, particularly in men, that we may have to be more concerned about cardiovascular health in our male population. And then finally, this study, which I thought was really interesting as well, this is another study that came from Scandinavia, from Sweden, following more than 20,000 Swedish men. They were registered into the military. They had compulsory service. So this went on for many years, from the 1960s to the early 2000s. So they were followed from their late adolescence into adulthood. And when they were divided into high, medium, and low cardiorespiratory fitness groups. So this was happening before they had any diagnosis of anything. This was just following people prospectively and see what happened to them over time. So they were either followed until they got psoriasis or psoriatic arthritis, or until 2016, if they got neither one of those. And then they analyzed the data, and they found that there was an association between low cardiorespiratory fitness and incident psoriasis and psoriatic arthritis. So that means that people who are less cardiovascularly fit have a higher risk, at least they found in the Swedish population, they had a higher risk of developing psoriasis. So I think that was kind of scary and gave me a little bit of pause. And that really argues for directing it for early in life physical fitness, and another piece of information to add to the association, and the stronger association between cardiovascular fitness and psoriasis, or lack thereof. Okay, and this is just a summary. So poor fitness at an earlier age may predispose men to psoriasis. All right, let's see how we're doing for time. Okay, we're okay. So triggers. I think this is an area that I didn't find a lot of amazing data on, but I tried to make some connections here where I could. So we know in general, there are known triggers for that people claim for their psoriasis, and some of these are highly evidence-based. We know smoking can make psoriasis worse. Weather changes can make psoriasis worse, especially cold weather where there's a lot less sun. It's sort of like you're not getting your natural light therapy to put your cutaneous disease into remission. Stress can make psoriasis worse. Infections can make psoriasis worse. So the things that I was looking at were things that have been reported in the literature, but associations hadn't been super strong in the past. One is nicotine. So we know nicotine can be associated with adverse cardiovascular events, high blood pressure, peripheral vascular disease, stroke, heart attack, even death. And there's a strong association between psoriasis and both current and former smoking. And seems to be an increased prevalence and incidence of psoriasis, of smoking in people with psoriasis. And some studies have shown that the more you smoke and the more intense you smoke and the longer you smoke, the higher your chances of having psoriasis. And we know that men use tobacco products at higher rates than women. So this may be an area where men have where nicotine has a higher impact on the male population than on the female population. I also looked into alcohol, because a lot of people report alcohol as a stressor for psoriasis, and that's been reported since back into the 90s, and we know that this has been supported by some evidence, but this data is really limited. I think the link between this trigger and psoriasis is a little bit less robust, but we know that there is increased consumption of alcohol and alcohol use disorders among people living with psoriasis, and some studies show that alcohol use prior to the onset of psoriasis may contribute to psoriasis development. But again, the evidence is not that strong. Alcohol use disorders is a 14% prevalence in the United States community-based samples, and about 20% of adult males actually have qualified for an alcohol use disorder at some point in their life. But that number, it goes down by down to 5 to 6% of adult females qualify for an alcohol use disorder. So this is something where the male population is going to be at much higher risk of having this potential trigger for psoriasis. Okay, sexual dysfunction as well. So we know that men with psoriasis and psychological comorbidities have been associated with higher degrees of sexual dysfunction. There was a really nice study that came out in 2019. This is a systematic review. So review of all the studies that were very high quality in one of our top dermatology journals. And they found that psoriasis patients had a greater risk of sexual and erectile dysfunction. And those with anxiety, depression, psoriatic arthritis, and genital psoriasis also at higher risk. And they found that biological drugs could be very helpful in this population. I think the question for me is, why is this happening, right? There is sexual dysfunction that can happen secondary to a higher prevalence of traditional risk factors for erectile dysfunction, cardiovascular disease, diabetes, chronic kidney kidney disease, but there are other risk factors that we have to, and that's just physiological inability to get enough blood flow into the penis and develop an erection, right? But there are other things that could potentially be contributing to sexual dysfunction rather than erectile dysfunction, which can sort of overlap with each other. And those risk factors may be depression, stress, relationship issues, neurological disorders, drugs, and a lot of people take medications for high blood pressure. They can have an effect. Anti-androgens can have an effect. Medications for depression can certainly have an effect. And then things that are given to people with endocrine disorders, like hormonal disorders, can have an effect as well. But I think it's important to try to think about these. We haven't really done a great job of teasing out these psychosocial stressors versus the true vascular disorders that may be contributing. But sexual dysfunction is indeed a problem in men with psoriasis. And then I wanted to touch on stigma. Let me just check how we're doing for time. I think we are okay. All right. About stigma actually coming from two different sources. This is something that I've been asked about as well. So there's social and public stigma. So the stigma that comes from the perceptions that are held by other people. And those social or public stigma, it really indicates that an individual is socially undesirable, and people who are sort of victimized, the stigmatized people may sort of internalize these prejudices that come from the outside world and then develop negative feelings about themselves, resulting in self-stigma. Okay, and this is a little bit different from internalized stigma, which comes from within. It doesn't come from the public perception. And in this internalized stigma, people cognitively absorb negative messages or stereotypes about illness. This can be psoriasis, or this can be about mental illness, and then actually come to sort of believe them about themselves. But again, internalized stigma coming from within, socialized stigma coming from the public, from without, and then being internalized and being absorbed. And I think that the reason why I want to talk about this is because men are affected by these as well as women. But as we know in the past, when we're looking at that data before, the lived experience, I said, of psoriasis is different between men, and women tend to report they're having these symptoms: anxiety, depression, lower quality of life, and men may not be as forthcoming about their mental health comorbidities. But anyone living with psoriasis, or anyone treating anyone with psoriasis, has at least one story about the social stigma coming from the outside world for people who are completely ignorant about what psoriasis looks like and what psoriasis means on another person's skin. And again, men may not be forthcoming about this. So this is something worth engaging with your doctor about if you are a man living with psoriasis, or if you are the loved one of someone with a man living with psoriasis. Okay, and then I'm going to briefly go through some of my tips. So what? All right. So I gave a lot of information, made it seem to be all over the place, but I think it's really important for us to understand male behavior, to try to develop rapport and trust between dermatologist and patient, because again, men are not going to be as forthcoming about this stuff, about their symptoms and about asking questions and about their information in general. So patient education is really important, and men in general want a lot of information before making decisions. And once they make the decision, they're going to go ahead with it, but they're much less likely to make a spur of the moment decision. Family and friend education is important. Public education is important. And then it seems like to me that lifestyle changes are critically important for men. And it seems like those lifestyle changes need to be happening at an early age, especially if we're looking at people of low cardiovascular fitness, even adolescents. Diet, weight loss, exercise, smoking, and alcohol avoidance. And then for people, particularly if people are living with severe psoriasis or psoriasis that has joint involvement or sexual dysfunction, multidisciplinary care is always recommended in interfacing with an internal medicine doctor, sometimes a cardiologist, sometimes even a urologist when there's sexual dysfunction associated. And then we're not talking about biologics today, but it's hard to get through a psoriasis talk these days without mentioning biologics. Biologics have good evidence base to decrease all these comorbidities, get moderate to severe psoriasis under control, including sexual dysfunction. Okay, I have a couple male specific tips. These are more like to do with skincare, but if you're a man with psoriasis, make sure your dermatologist is checking all of your skin, not only for skin cancers, but in the groin, on the genitals, in covered places like the back of the buttocks, the back of the scalp, because these are high yield places for psoriasis. And these are places where psoriasis can really mega impact quality of life. Avoid traumatizing your hair, gently brush it, try to get your meds onto the scalp and not onto the hair itself. That's not where they're for, because the psoriasis is inflamed on the scalp, not on the hair itself. And dandruff shampoos can be used regularly, but using them too much can actually dry out the scalp and make things even worse. Same thing goes with beard. We can see psoriasis in the beard with the Sibo Psoriasis pattern. Gentle cleansers, oils and conditioners can detangle, and then it's advisable to use electric razor and scissors to try to avoid the Kebner phenomenon. And then with genital psoriasis, I think it's important to destigmatize it. It's safe to have sex, okay? Genital psoriasis is not infectious or contagious. And the topic of speaking with your intimate partner about genital psoriasis is probably one that we could talk about at length at another time. And I would be interested in how people are speaking with their intimate partners about this. But let people know it's safe to have sex. Avoid avoid it if the skin is raw, but cleaning and lubricating out and repairing afterwards is really important to avoid traumatizing the skin and inducing new lesions. And again, talk to your dermatologist. Again, biologics can help clear the skin and improve quality of life. So in general, I would just sum up by saying that men in general are pretty poor consumers of healthcare and poor participants in self-care, okay? And our experience between men and women looking at psoriasis is different. The cardiovascular burden and the relationship between cardiovascular morbidity and psoriasis in men is complex and may be more severe in men than it is in women. Psoriasis can affect sexual dysfunction, but our response to systemic medications is strong. And it's really important to be engaged in your treatment, talk to your dermatologist, talk to your friends and family about this, and talk to your intimate partners. And I will stop sharing right now, and then we will go to Q&A.
Thank you, Dr. Morassi and Dr. Rieder. And especially Dr. Rieder, thank you for bringing up that stigma about the mental health that is not discussed enough. So as part of the psoriasis community, we thank you for bringing that up and addressing it. So right now we are going to do some Q&A. So if you guys want to go ahead and put your questions in the chat, Bev is going to go ahead and get those for us for Dr. Rieder and Dr. Morassi.
Great. We do have one question for Dr. Morassi already. Dr. Morassi, when it comes to birth control, is it just as effective in a woman who is on a biologic? And also, is there a risk for a woman with psoriasis that she should be aware of going on birth control while being on a biologic?
So all biologics do not affect birth control efficacy, meaning how well the birth control works. So there isn't concern about that. On occasion, patients will be placed on azathioprine, which is also called Imuran. It's usually used for atopic dermatitis and not psoriasis, but that medication in particular doesn't have as much doesn't have as much efficacy with an IUD, an intrauterine device. I didn't talk about Imuran because it's less likely to be prescribed in psoriasis patients. So basically the psoriasis treatments in general do not affect the how well birth control works.
Okay, thank you. And for you both, let's just talk a little bit about genital psoriasis. Are the medications over-the-counter products any that should be avoided? Are there differences between male and women?
Maybe I can start with this one.
Yeah.
I'm not sure if my video is on. Can you hear me?
Yes.
Okay. I'm not seeing myself in the video, but that's cool. So I think in general, I don't know of any major differences between products you should use in men versus products you should use in women. And in general, what I think about with psoriasis products in the skin that are available over the counter is that you want to use something that's hypoallergenic, that's fragrance free. A lot of people like using ceramide based creams to try to repair the epidermal barrier. But I think you want to stay away from things that are going to have fragrance and going to be something that could potentially cause an irritant or an allergic reaction, because the key is going to be in repairing the skin barrier. If the skin is really raw, I do like using, it's not the most cosmetically elegant thing, but I do like using zinc oxide paste, because that's the best thing to go on. That's what you put on like a baby's bottom as well. It goes on thick, it goes on like almost like frosting on a cake, and then it hardens, and that really lets the skin repair from below. Again, not cosmetically elegant, probably going to get all over your undergarments, but when things are really, really chafed, that's what I recommend. But again, my take home is just fragrance-free, hypoallergenic, ceramide-based creams or ointments.
I agree with all of those suggestions, and just to add in terms of therapy, the groin is an area, so we're covered in organisms on our skin and in our gastrointestinal tract and our respiratory tract. We have 10 times the amount of other organisms on our body's DNA than our own human DNA. That's how many yeast and mites and bacteria are on our skin. And in the genital area in particular, there's a lot of microorganisms that kind of live with us in harmony. We call it the microbiome. And so if you use topical medications in the groin area, it's very easy to get infected. Normally psoriasis doesn't get infected, but inverse psoriasis, meaning psoriasis in the armpits and the groin, because they're moist areas where these organisms are present, they can get infected. And so examples would include bacterial infection as well as yeast infection being the most common. And so if you feel like your genital psoriasis is worsening, it's important to do things for, the question was regarding over the counter. So you can do vinegar soaks, 1 part vinegar to 5 parts water, soak it in a washcloth and place in the groin, and that can help to reduce the organisms. Also things like Hibiclens, which is spelled Hibiclens. Hibiclens, it's also called chlorhexidine gluconate, but that soap will reduce, it's broad spectrum, like vinegar is broad spectrum, so it's going to reduce both bacteria and yeast. I tend to use a lot of vitamin A topicals like calcipotrione, also called Venex. Particularly, I find that's helpful in the genitals because chronic use of cortisone, so high cortisone can predispose to genital infection, or mixing an over-the-counter antifungal like clotrimazole, for example, with the hydrocortisone to kind of reduce the chance that you get an infection. Another therapy that I find very helpful specifically for genital psoriasis is Eczema Laser treatment. So if you're on, for example, biologic medication, but the genital psoriasis is just not budging in the way that you want it to budge, to get it to clear up, because that's such an uncomfortable area for both men and women to have genital psoriasis. The Eczema Laser is a spot size about this big. You can use the National Psoriasis Foundation website to help find phototherapy units in your area that have eczema. So it feels warm on application, kind of warm light. And I find it very effective for genital psoriasis specifically, whereas if you go into a light box, that area is not necessarily exposed, but genital psoriasis tends to respond very quickly to the Eczema Laser. So those are some therapeutic suggestions to help with genital psoriasis.
Great, thank you, Dr. Murase. And Dr. Rieder, we have a comment, and maybe you can talk a little bit more about this. While Scandinavian studies may be interesting for the reasons you cite, we should be cautious about taking lessons from this for the US and other countries since healthcare systems vary. Would you like to comment back on that statement?
Sure, I think it's a great comment. I have a great fondness for Scandinavian countries and the way the Scandinavian countries do their healthcare. And I think that the reason why I think that they're the studies are interesting is because they have so much more data available to them and everything is centralized. I think it's hard to make conclusions and sweeping generalizations because their patient population is so different. I mean, the climate is completely different. They're at much higher latitudes, so their winters and their summers are different, and the patient populations there are inherently large. A huge majority, the overwhelming majority of them are white skinned. Okay, so it's hard to make generalizations, especially when you're looking at the United States population, because our population is so much more mixed and heterogeneous. But I think it's a really valid conclusion. But I think that they are the model of how epidemiological studies should be done. I just wish that we had a system in the United States that could replicate what they do. But it's a great comment.
Great point. And you mentioned Sibo Psoriasis. Can you talk about what that is, and is it treated differently?
Yeah, so Sibo Psoriasis is basically the confluence of seborrheic dermatitis and psoriasis, which tends to happen on oily skin areas. Really common to happen in men, but can happen in women as well. And typically happens in areas where those hair-bearing areas like the central chest can happen in men. It happens in the beard area, the mustache, the scalp, and it can sort of track down onto the forehead as well. So seborrheic dermatitis is just bread and butter dandruff, and then psoriasis of the face. Psoriasis of the face really only affects about 15% of the population, but it can be sort of messy and greasy. And that's a really tough area to have psoriasis because it's an area that's completely exposed at all times, regardless of the weather as your face, except for, I suppose, the lower face during the COVID pandemic. But the treatments are not especially different because I'm still using shampoos, and especially if you think about a male population, men don't like, in general, men don't like to have as much in terms of creams on their faces. So I'm recommending that people use the same shampoos on their scalp, on the hair-bearing areas of the face. So I help people lather it onto the eyebrows, into the mustache, onto the beard. Sometimes it affects the nasal labial fold, so that skin between the sides of the nose and that goes down to the corners of the mouth. These are all common places that Sibo psoriasis can affect the face. But again, so usually some combination of dandruff, shampoos, or antifungal creams, and then a little bit of topical steroid from time to time to get flares down. Sometimes we have to put people on steroid-sparing agents like pimecrolimus and tacrolimus, but often I can get people clear with limited Sibo psoriasis just by the use of intermittent topical steroids, like a week here and there, and then a regular intermittent use of an antifungal.
Okay, great. Thank you for expanding on that. And do you have any comments about shaving? You mentioned shaving tips, but I'm curious for not just men, but also women. So this question is for you both. Can you offer any tips about shaving with psoriasis?
Dr. Morassi, do you want to start? Or do you want me to?
You're talking about just shaving the legs, for example, would be the most relevant for women's health. I do have a lot of patients that will get laser hair removal in order to try to limit trauma, particularly if they're getting folliculitis, which is when there is a follicular infection. Usually it's bacterial when it occurs from shaving on the lower legs in women. It's really important to make sure that the razor is cleansed frequently, and that you can also, get disposable razors as well, or use alcohol to cleanse if you're having difficulty with shaving the legs and it's getting recurrently infected. The blade could be a source of the infection, but if it's recurrently an issue, and the hairs are coming back very coarse, and you're getting spots on your legs that are uncomfortable, I think for women, laser hair removal is a good option. I realize that that's not an option for the face, so I'll let Dr. Rieder talk about men and shaving on the face.
Yeah, it's hard because your facial grooming style plays a role in this as well. And I'm a guy who I have some sort of beard at all times, so it's a lot easier for me to tell people just to use clippers and not to traumatize your skin and worry about the Kebner phenomenon. But in general, what Dr. Murase said about rotating, like getting new blades every time you shave. And I think with guys, it's really important to, there was like a trend for many years when I was growing up that these companies wanted to have more and more blades. It was like 2 blades and 3 blades. And now we've gone to 5 blades. And like, this gives you like a really nice, clean shave and it feels really smooth, but that's the best way to traumatize your skin. It's also the best way to get ingrown hairs. And the problem with ingrown hairs is that our body, once they can't get out, they kind of curl around and then they can develop an inflammatory response. Same thing happens with men and women with thicker hair types. Asian hair and hair of African descent, it tends to be thicker and curlier and can curl, once it comes out of the skin, it can curl back on itself and then poke back into the skin. And the body has like a foreign body response where it doesn't recognize the hair as your own. And you get ingrown hairs, not ingrown hairs, you get an inflammatory response and you can get bumps and inflammatory lesions. So when people are, if you can keep the hair short but not completely shaved down clean, it's advised to use clippers. But if you want to shave clean, it's important to get a new razor with every shave and to use a razor that has like 1 or 2 blades max and shave with the grain. This goes for women as well on the legs, I believe, because I see a lot of, I don't see so much psoriasis induced by shaving, but I do see a lot of dermatofibromas, which are sort of unsightly, thick, hyperpigmented bumps that women get on their legs all the time and drives people nuts. So I think all those things can be really helpful, but also shaving right after showering when the hairs are warm and they're a lot softer are very helpful to do. But everybody has a different set point when it comes to shaving. Those are generalities, which I recommend. And obviously like moisturizing afterwards and using aftershave gel can be helpful as well. But for some people, it's hard to say specifically like at what point is like the hair at an appropriate length and what length is too short and whether it's going to be a problem for getting ingrowns. But those are the generalities I tell people with shaving.
Just to add to that, there is a product that was developed by the military that's over the counter. It's called PFB. So P, F as in Frank, B as in boy, and then new word vanish. It was developed by the military because there's 4 different kinds of what we call hair curl indexes. And so patients with a higher hair curl index, as Dr. Rieder said, the hair can go back into the skin and cause inflammation because that keratin protein of the hair is very inflammatory. So this product was designed because the patients that had, or I should say the soldiers that had higher hair curl index were getting a lot of what we call superfluous bar, which is these bumps from shaving on the face. So if you're experiencing that, that's another product that could be used. I saw in the chat that there was someone that mentioned that they get very red after shaving. And one of my areas of interest within medical dermatology is actually allergic contact dermatitis. So patients with psoriasis can get allergic contact dermatitis as well. So if you're having issues where you're currently getting rashes, using getting a patch test, an allergy test to look for what shaving products are good for you is an option that you have. So it's essentially a test where they put stickers on your back and look for things that are commonly in cosmetic products that can cause rashes on the skin. I've seen rashes to things that are fragrant, both on the face and on the lower legs when people are shaving. And that would be a way to identify what could be triggering. The Mayo Clinic developed a product line called the Vanacream and Free and Clear line. The Vanacream shaving cream that's used in that line has very low allergy risk products, or I should say ingredients. So it's a Vanacream shaving cream that I tend to recommend if someone is suspicious that what they're using is actually triggering the issue.
I just want to second the Vanacream. I have no financial interest in that company as well, but for people with irritated or allergic skin, Vanacream is amazing. And then just to say one other thing to piggyback after what what Dr. Murase said, if you think that you may be having some irritation or allergic reactions on your skin, it's important to get that testing done by a board certified dermatologist. And the testing that's done by allergists is prick testing, and that goes tiny little pricks of different substances that go in like your forearm, and they're not testing for things that are commonly found in skin reactions.
Okay, great. Thank you very much for being here today. Looks like we have some questions that we'll need to chat individually, but beyond that, thank you very much for talking about the differences between men and women. It was very intriguing, and I hope people will take certain messages to heart about what they heard today. And thank you for being here today.
Pleasure. Thank you for the invitation.
Yeah, thank you so much for having me.
Thank you, and I'll turn it back to Jane.
Okay, you guys, we've been sitting a little, so we're gonna go ahead and take a 5-minute break. You guys definitely deserve this. Go ahead and stretch, grab your favorite beverage, a snack. We are going to go ahead and show some slides. We're gonna scroll through some information. For those who are new to the NPF, it'll be some great resources on how you can get involved, where to find different resources. And if you have any questions, Audrey is working hard behind the scenes. Go ahead and put them in the box and we can get back to you guys to answer those. So go ahead and enjoy that break.
Actually, Jen, I think let's extend the break since we ended a little early. So we'll be back with our next session at 10:45, but sorry, 10:45 Pacific time. So in the meantime, take a break and look at the slides we've got coming up next.
And for those who are actually going to stick around or can still hear, I'm going to talk just briefly about some of the slides and some of my experiences here with getting involved with volunteering. Psoriasis.org, it's a great family outside of a family to find and connect with those who also have psoriasis, and we all have talents. I know we've got Ms. Tammy on here who has raised money with her talents of getting some bands together and getting people together just to celebrate. And as Jim just put in the chat, it's a family. Our family. It is, like I said, a family outside of a family. So we're always looking to grow our family as well. And I'll also speak on this one, the one-to-one program. You know, I've had psoriasis for 23 years, I think. I lost count after 20. But even being newly diagnosed or somebody who's had it, it's just nice to have somebody and have that resource to be able to connect with somebody who understands what you're going through. So this program definitely is great support, but it also, I always tell people that I'm at my best when I'm helping others, hence why I became a nurse. But especially with psoriasis, it gives my disease purpose. It's something that it's not, just an annoyance to what I have. So the one-to-one program gives, purpose, along with also helping if you don't know your direction or you just want somebody to talk to.
And if you're a parent of a child who has psoriasis or psoriatic arthritis, visit our spot at psoriasis.org/our-spot. You'll find all sorts of information for parents, teens. We do have a welcome kit that you can request for free, but it is for kids with age-appropriate information. So please visit today and see what resources are available. We recently added a playlist just for parents that includes all of our webinars and podcasts.
Well, and as Director of Patient Services, I'd love to put a plug for the Patient Navigation Center. If you haven't reached out to them, or if you're looking for more resources or needing to find a provider or have questions about accessing your treatments, contact the Navigation Center. We've got 4 wonderful navigators that are just waiting during the week to talk with you or email with you. And the information is there. We are open from 7:30 to 4:30 Pacific time, Monday through Friday. So we still got about 10 minutes left in our break. Enjoy the time, grab a beverage, stretch your legs, get a little cardiovascular exercise in there, like Dr. Rieder was talking about. Well, we've just got a couple more minutes left on the break, actually about a minute. So if you are in earshot of your computer or your iPad, come on back and we'll be starting up in just about a minute.
Welcome back, everybody. I hope everybody enjoyed that quick little break we had. So moving forward, I'd like to introduce Dr. Stevie Don, who serves as CEO of Stevie Dawn Inspires, a platform dedicated to helping people be productive at work and happy at home. Whether it is through corporate training programs, leadership development days, coaching entrepreneurs, or speaking at conferences, Stevie Don always delivers high energy, impactful sessions. With a variety of experience in the corporate, nonprofit, and governmental sectors, her educational background includes a master's degree in sociology from Wichita State University and a doctorate in leadership from Colorado State University. With over 20 years of teaching and training experience, we're excited to have Dr. Stevie Don with us today. Welcome, Dr. Stevie Don.
Hello, everyone. Thank you so much for having me. As I am getting my PowerPoint up and ready to share, I would love to just see and hear from everybody in the chat box. So go ahead in the chat. Let me know, what are you hydrating with today? I know it is all different time zones. We are in all different places. Some people are still having their first cup of coffee. Other people are on water. Where are you at? I can tell you I am having a Diet Coke today. That is my hydration for the next hour. I know it's not the healthiest. I know we've got some doctors on here who would be talking to me about my Diet Coke habit, but it's going to get me through the afternoon, and that's what we need. So go ahead in the chat, let me know what you are hydrating with. I'm going to get my PowerPoint up. If somebody could give me the ability to get my PowerPoint up on screen, that would be great. There it is, awesome. And somebody who has their camera turned on, could you please just give me a thumbs up that you can see my slides? If you have your camera turned on, give me a thumbs up. My slides, that way I know they're there. Thank you, Jennifer. I appreciate you so much. I see the thumbs up. There we go. Awesome. So let's see what we're hydrating with. We've got water with lime. We've got some tea, black coffee for the win. Jim, I'm with you, although mine would have all the cream and sugar, I have to admit. Audrey, this is how I know we're connected. We're both having the Diet Coke today. We've got an Arnold Palmer, coffee and water, more water, Earl Grey tea, back and forth between coffee and unsweetened iced tea. There you go. Diet Coke here too. Savannah, we can make a tribe. We are the Diet Coke today. I love it. So I am going to talk to you today about emotional resilience. And one of the things that I think makes this topic so powerful and so important is that it's something we all need and something we all struggle with at some point in our lives. So I'm going to spend about the next 45 minutes or so talking to you about emotional resilience, but I'm definitely going to give you some opportunities to put some things in the chat, to answer some questions, to give some validation and some examples to each other. Because while we may only be connected through the internet, that chat box is our lifeline, right? It allows us to be there for each other, to support each other, to connect to each other. And we're going to see how that's important as part of emotional resilience. So I'm going to ask you to keep that chat box open. If things I say spark something in you or make you think of something, put it in the chat box. Even if it's just an amen, this is good. We like those too, right? Especially as a speaker. And then also, if you have any questions, I'm not going to necessarily make you wait till the end of our session to do Q&A. I like to just pop in and answer questions as they pop in the chat. So pop your questions in the chat as we go. I will answer them as we go through this content, but I'm just so excited and so grateful to be with you here today. Now, for those of you that might have seen me speak before, you know that I don't start any presentation without a story. And so today I thought we would start with a dog story, y'all. So if you're a dog lover, put a 1 in the chat. If you're a dog lover, I am a dog lover, a cat lover. I'm an all animal lover, except maybe snakes. But that's me. If you're a dog lover, 1's in the chat. Nicole's a dog lover. Kristen is a big dog lover with lots of 1s. Leah, Jason, Jennifer, Jim, Jane, Tammy. Love it, love it, love it. All the dog lovers in the house. Okay, here's our story. I just want you to sit back, take this in. So I want you to imagine a little boy. He's about 8, 9 years old, and he loves to duck hunt. His dad has taken him out, taught him how to duck hunt. And so he has been so excited about this whole new hobby, this whole new world, that he's been begging his parents for a puppy. I mean, what little boy wouldn't beg his parents for a puppy, right? Especially one as cute as this one, right? So he's begging his parents for a puppy, and his parents are like, you know what? You've been a good boy. You've been doing all the things right. We're going to get you that puppy. So, right? He gets the puppy and he starts training that dog. He trains the dog to sit and stay. He trains the dog how to swim, how to retrieve, which means go and get the duck and bring it back. He gives him all the commands, and this dog works hard. He knows all his commands. And then it's upon them. Duck season is open, and he's so excited. The first day he gets up super early, gets all dressed, takes his dog out, and they're out there and they're shooting things, they're seeing things. And then there's that moment. He shoots that duck, the duck falls in the pond, big splash, right? And the little boy says, retrieve. And the dog goes running. But instead of all the other times they've practiced where the dog swam out to the lake and grabbed the duck and brought it back, oh no, not this time. This time that dog ran so fast, his feet were just on top of the water, running so fast. He picks up the duck, brings it back, drops it at the little boy's feet. And the little boy goes, I have a miracle dog. I have a miracle dog. I got to tell somebody. You got to tell somebody when these things happen. And so he goes to his neighbor's house. He knocks on his neighbor's door. Neighbor, you got to come see what my dog can do. And the neighbor's like, sure, let's go out tomorrow morning. They get up in the next morning. They get ready. They go out. They're doing all the things. And the dog is obeying every command. And then there's that moment where he shoots the duck falls in the pond with a splash. He tells the dog, retrieve, and the dog goes running, just paws don't even get wet. He runs so fast to top the water, brings the duck back, drops it at the neighbor's feet. And the little boy looks up at the neighbor and he says, so what do you think? And the neighbor goes, I hate to tell you this, but your dog can't swim. Now, there are lots of things we could choose to take from that story. I'm sure some of you are thinking of all of them right now. Lots of things we could take from that story. But here's the thing I really, really want you to remember. And that is this. Sometimes as humans, especially as adults, we start looking for all the negative. We start looking for the dog that can't swim, and we forget that there are miracle dogs. And I would hazard a guess that some of you forget that you are the miracle dog, right? There are always things we can pick apart about ourselves. We can always be our own worst enemies. But at the same time, we all are miracle dogs. And one of my goals with emotional resilience is to help you be able to activate that and get to that place where when the times are tough, you don't focus on the dog that can't swim, but you focus on being the miracle dog, right? We just did a live event this week. And one of my favorite things was to have everybody stand up and say, I am the miracle dog. I feel that's really powerful. So if you want to do that in your home right now, you just go ahead. We won't even need videography to make sure that you do it. You can just do it on your own. But I think it speaks to this overall message of what emotional resilience is. It's this ability to bounce back from hard times. It's this ability to see good things, even when you're surrounded by all the negative things. And it's that ability to keep going, to persevere. So today I want to share with you a couple of different strategies for how to pick yourself up in tough times, and hopefully give you a little bit of inspiration and motivation to remind yourself that you are a miracle dog, and then to take that story and remind others that they're miracle dogs too. So let's start with this. On a scale of 1 to 10, we're just going to do a little pulse check. How are you feeling today? Scale of 1 to 10, 10 being today is awesome. This conference is so amazing. I'm learning so much. 1 being, you know what? I'm really tired. I just want to go to sleep and have it be tomorrow. Totally okay. We've all had between a 1 and a 10 day. My only request is no fractions, because I hate having to do that math. But somewhere between 1 and 10, go into the chat. Let me know, how are you feeling right now today? Put it in the chat. How are you feeling today? Okay, I see 10s, 9s, 7s, 9s. Jim, 9.82763576575. Okay, good. I'm just going to round that up and call you a 10. All right, 6, 7, 9, 10, 8. Yes, 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 yes. Awesome, awesome. So here's what I want you to think about, right? Here's what I want you to think about. How does that number impact everything that happens in your day-to-day? How does that number impact everything in your day-to-day? See, what we know is that when we're feeling bad, and I really would love to meet people who've never had a bad day, but in my experience, we've all had a bad day at some point, right? We've all had a bad day at some point. And so I want you to think about, on those days where you have bad days, isn't it harder to do everything? Like, it's harder to send emails. It's harder to get out of bed. It's harder to have conversations. Like, when you're having a bad day, everything is hard. When you're having a good day, everything is easy. What happens to most of us is we forget when we're having that bad day, that bad moment, that we really are in control. We can change it. We can make it better. We can do things to bounce our mood and our attitude back up, but we forget. And we allow ourselves what I call a wallow, right? We allow ourselves a wallow time to just be stuck in our bad, right? What I like to say, and please excuse my language, we're stuck in the suck, right? It sucks and we're stuck there. And so I think we have to be thoughtful of, how are we feeling? And then how do we bounce that feeling up? How do we change that feeling when it happens? Because so often, right, what we see from people is that they get stuck in the bad, right? And what that does is that makes it so they can't move forward, and they bring down everybody around them. Do this for me. If you've ever been in a situation where you had somebody around you who was having such a bad time that you were brought down with them. If that has ever happened to you, put me in the chat, right? Put a me in the chat if that's ever happened to you. I know it's happened to me. I know I've been that person for somebody at some point too, right? I know I've been the person who was so negative that I dragged people down with me. We have to be thoughtful of that. Right? We impact so many people. I don't know what your profession is. I don't know what your career path is. I don't know your family structure, but I can tell you this: you are a leader. Every single human is a leader in their life. And in your life as a leader, it's really important that we remember our attitude affects everything, and it affects everyone. And so instead of making it a bad day, can you make it a bad moment? Right? Can you make it a bad 5 minutes? Instead of a whole bad day? Can you make it a bad day instead of a bad week rather than a bad month? I can tell you that the last several years have been very, very tough on all of us in all kinds of different ways. But the truth is, we can't allow ourselves to sit in it. We can't allow ourselves to wallow because it hurts everything and everyone around us, including ourselves. We have to pick ourselves back up. That's resilience. Resilience doesn't mean you don't get knocked down. Actually, I think the most resilient people get knocked down a lot. Resilience is about how you pick yourself back up afterwards. And that's where the power is. So I want you to look at that number that you typed in today, and I want you to think about if every single day you did this, we call this a pulse check. If every single day you did this pulse check, you got up out of bed, you got ready, got your day started, and you said, okay, before I do anything, scale of 1 to 10, how am I feeling? You put a number to it. What if I challenged you to say that that number is going to go up and down throughout the day, but I want you to try your hardest to make sure that number is above a 5 by the time you get home, by the time you get done with the day, by the time you get done with work, whatever that evening personal time looks like for you. And here's why. And I found this phrase years ago, but it has really stuck with me and made a big impact in my life. And that is, you give your work the best, but you give your family the rest. Think about that. You give your work the best, but you give your family the rest. I think a lot of us put so much of ourselves into our work and so much of ourselves into what we do every given day that sometimes we're so exhausted by the time we get home, we don't give to the family, right? That number has dropped during the day. And then by the time we get home, we're a 2 or a 3. And I remember being like that for myself with my family, being stuck in a place where I would give it all at work and then come home and be so tired, so exhausted, I could not give anything to my family, right? And that to me was a sign that something needed to shift in my life. And so the shift I made is this number. I started focusing on how I could lift this number through the day so that at the end of the day, my family got just as high a number as work would get. So if you wake up in the morning, you're feeling a 7, you're feeling an 8, how do you throughout the day make sure you keep stretching back to that number? We're going to give you some specific strategies today to do that, but I just want you keeping this in your mind, because when it's in your mind, you can start changing things and seeing things differently because you're focused on building yourself back up, getting that number nice and high so that when we get home with our families, when we have the personal time, we still have energy and space to enjoy it, right? And I think that's such a critical part of all of us, of our success in our life. Right? So I want you to keep this pulse check in mind as we go through our time today. And I would challenge you to think about, how do you keep that nice high number through whatever the rest of your day brings after our session? Because I think that this conference obviously is inspiring and motivating. It's answering questions for you. And that's great. How do you keep that energy going through the day? And that's what we want to focus on. So let's dive into one of the first things you can do to really shift that number, right? Shift that number back up, gain some resilience. The first strategy that I want to share with you is emotional reframing. Now, a lot of you have seen this before, have heard this before in some other place. If you've done any kind of self-development, personal development work, you've probably seen something similar to this success model. And I tried to use some Mardi Gras colors because, hey, it's that time of year. Here in the United States, I was like, hey, some Mardi Gras colors. So here's what I want you to think about with the success model. Our beliefs activate our emotions. Now, most of us, our emotions come from hormones. Hormones fire in our body, and that feeling that those hormones and chemicals give us, that feeling is our quote unquote emotion. We just label it differently, right? So our beliefs activate our emotions. Our emotions, how we feel, then influence our behaviors. I think most of us are used to that, right? When you feel good, you do good. When you don't feel good, you don't do so good, right? And we were just talking about how it impacts your day, right? So how you feel is going to impact the behaviors you take. And then our beliefs dictate our outcomes, right? And again, our behaviors dictate our outcomes. And I think a lot of us are used to that, right? If I do this behavior, I get this result, right? So behaviors dictate outcomes. The real key that a lot of us forget to consider is that our outcomes typically confirm our beliefs. At the end of the day, one of the most powerful muscles, probably the most powerful muscle in your body, is your brain. And when your brain decides to focus on something, heaven and earth move to make it happen. So if your brain decides to focus on what it wants, typically it gets what it wants. What I have learned in my work, I do a lot of private coaching and a lot of group coaching programs, a lot of inspirational, motivational speaking. And what I have seen in my work is so many of us aren't really thinking about our beliefs. We don't really think about our thoughts. We just kind of go through our day and assume that it's going right. And then our outcomes aren't what we expect. And I have two examples for you that hopefully will kind of show you this in action. Right? Let's do a personal example first. So let's think that maybe you're somebody who wants to work out or wants to lose a little weight, right? I think that happens to a lot of us. So let's imagine I get up in the morning, I stand in front of my mirror, and I'm looking at the mirror and the thoughts in my head. Man, I'm getting fatter. Man, I look tired. Man, I feel tired, right? All of these thoughts. Negative thoughts start going through my mind. Those negative thoughts are going to activate negative emotions, right? And I'm going to feel guilt, shame, depression, self-doubt. Those emotions then, what do those lead to in behaviors? Well, I'm not one of those people who, when I feel bad, I work out. When I feel bad, I eat mint chocolate chip ice cream. That's what I do when I feel bad. Okay, I don't know if anybody else, right, has had this experience, but when I feel bad, I eat mint chocolate chip ice cream. So now I've eaten my mint chocolate chip ice cream. That's my behavior. What outcome am I going to get? Well, I'm probably not going to be any more fit tomorrow than I was today. So in the end, that outcome reconfirmed, right, that belief of I'm already overweight. I'm already not looking the way I want to look. Right? It's a vicious cycle that we get stuck in. Now, if we could flip that, we could quote unquote reframe that. Then we could say, okay, in the morning when I'm having those beliefs about not liking how I look, I could change those. I could push the pause button and say, whoa, but your body got through a pandemic and your body is stronger now than it used to be. And you're comfortable in your own skin. That's a good thing, right? I could change those to positive thoughts. And those positive thoughts then would lead to more positive emotions. Now I feel self-confident. Now I feel secure. Now I feel pride. And those more positive emotions then would lead to what behavior? Well, when I'm feeling good, I actually do enjoy working out. So I'm actually in my office right now. My little Peloton bike is right across from me. So every time I do this, I'm reminded to work out. That's another story for another day. But anyway, so I think, oh, I'm feeling good. I look good. I feel happy. I feel successful. I feel proud of what I'm doing. Oh, great. I'll jump on the bike. Well, once I jump on the bike, what happens? Well, tomorrow I probably am feeling stronger and better, and I'm actually getting fitter. Right? All because I changed the thoughts, right? If you change your thoughts, you'll change your life every single time, but it's about changing the thoughts first. And so one of the things that I struggled with early on in my life was I didn't take the time to consider my thoughts. I always just stopped at the feelings, right? And I said, well, I don't feel good today, so I'm just going to sit here. I'm just going to wallow in it, right? But that's not what helps us. What helps us is to reframe those thoughts and switch to something more positive. But so often we don't stop ourselves and give ourselves new thinking. But thinking is what matters. Change your mindset, change your life. So if we can change our thoughts, we can change everything around us. So what that means for me is when I'm starting to feel that number slip, right? Taking it back to that pulse check we did, I'm starting to feel that number slip. It was an 8, slipping down to a 6, slipping down to a 4. What can I look at in my life that needs to be reframed? Instead of saying, gosh, it's a bad day, it's a rough day. How about I reframe that to, okay, that was a bad moment, but I got some great stuff coming up this afternoon. How do I reframe those thoughts and change the whole outcome? Just by trying to think about something on the more positive side. Now, don't get me wrong. I still think we have to be realistic. I think we have to admit that bad things happen. We can't just Pollyanna it away. But if you take control of those thoughts, you can start raising that number, but you have to take control. Now, let's look at a professional example, just to give you another example. Let's say that you were going up for a promotion at work. And let's say you got up that morning and you started doubting yourself. Well, I'm not sure they're going to give it to me. I'm not sure that supervisor likes me. I'm not sure I have the experience they need. These are your thoughts. What emotions is that going to bring? Self-doubt, lack of confidence, insecurity, anxiety. With those kind of emotions, what is the behavior going to be? You're probably going to stumble over your words. You're probably going to sweat. You're going to shake, and you're not going to appear confident. Well, then are you really going to ace the interview and get the job? Probably not. Whereas instead, if you woke up and as soon as you started seeing those negative thoughts appear, you started to go, whoa, whoa, I can do this. I'm ready for this. I have this potential. Then you shift those thoughts, you can shift that whole cycle. And so I think it's really important that we realize how powerful our brains are and how much they can control how good we're feeling in the day. A lot of people think of emotional resilience around the emotion part, but I'm going to tell you, emotional resilience is 100% about your mind. It's not about your emotions. Your emotions happen. You feel them. You have to process them. They are a chemical reaction, a hormone shooting through your bloodstream. You have to work through it. You have to get through it, right? What you can change are your thoughts. Your thoughts can change. And when you change your thoughts, those will activate different parts of your body. That's going to give you different feelings. Then you're going to feel better and you're going to have a better day. I'm going to do one more example, just because I always like to make sure everybody kind of understands this concept of what we focus on expands, which I know is a statement that a lot of people use. Let's do this. So when I wanted to go test drive a new car, right? This happened several years ago. I wanted to go test drive a new car. We needed a new car in our family. We were trying to decide what we had. I started thinking about, I would really like to test drive a Chevy Malibu. Why a Chevy Malibu? Because a friend of mine had one in like a navy blue and it was really pretty and I loved riding in it. I thought it was great, right? So I started telling my brain, Chevy Malibu. I want to test drive one of those Chevy Malibus. And then what started to happen? Every stoplight, I see 10 Chevy Malibus. Every grocery store I park and I'm parking next to Chevy Malibus. It's like I'm now surrounded by Chevy Malibus everywhere. And I ask myself, are there more Chevy Malibus on the road today than there were yesterday before I just had this thought? No, there aren't. Your brain gets pummeled with so much data, so much input. It chooses what to remember and what to show you, what to bring awareness to. I told it, please show me Chevy Malibus, and it brought me Chevy Malibus. If you've ever had something like that happen to you, put a 3 in the chat for me. If you've ever had something like that happen to you, whether it's around cars or maybe around songs, you think about a song and then all of a sudden the song is playing on the radio. If you've ever had that happen, put it in the chat, because I think it's important that we understand this is how life works. Our brain decides what it's going to show us. So you can control this, you can control everything, right? Because we're starting to tell our brain, here's what to focus on. I cannot tell you how many times in my life I told my brain, please show me all the things I'm doing wrong. Please show me where I'm failing. Please show me all the negative in my life. I didn't realize I was doing that, but that's what I was doing. And then of course it shows it to me and then I'm upset. Right? We have to understand that what we focus on expands. And if we know that, and if we can get our hands around that, understand that concept, we can shift everything in our life just by learning how to focus our thoughts differently. And that has been the game changer for me in my life and my success. has just been changing those thoughts. And I see I'm not alone. People have had this happen to them as well. I'm so glad. Sometimes I tell it and people are like, no, that never happened to me. And I'm like, well, then it's not a very good example, I suppose. But I'm glad some of you have had that happen, so you understand this concept, right? So we're going to talk about a couple different strategies to help you promote resilience in your life. But I always start with emotional reframing because it is the most powerful, right? Think better, feel better, do better. Think better, feel better, do better. That's written up on my wall over here on my vision board, right? Think better, feel better, do better, right? So how can you focus on things to improve your resilience, improve that number and spike it up? So we're going to go through 4 more. That's the most important one, but we're going to go through 4 more. First one we're going to talk about is personal triggers. Okay, we're going to talk about how do you trigger yourself into feeling better. And we're going to talk through some of those. We're going to talk about the need to persevere and how you can make perseverance part of your strategy. We're going to talk about compassion and the importance of compassion, which I think everybody understands. And then we're going to talk about how support intersects with resilience, because it's really an interesting find in the research. So here we go. First thing, right? We do emotional reframing. Second thing then we're going to talk about is triggering happiness. I want you to think about for a second. Just take a second, close your eyes and think about it. What are some things that bring you happiness and joy in life? What are some things that bring you happiness and joy? You know what? Share them in the chat box. Let's get some happiness and joy vibes going today, right? So what are some things that bring you happiness and joy in life? Put them in the chat. Let's celebrate all of the goodness. Some people are saying dogs, being out in the yard, sunshine is a big one for me. Music, I love music. I love dancing. All of these things are good for me. Traveling, family time, knitting, husband, animals, right? My PSO family, absolutely. Dogs, the beach, family, friends, the ocean, beer. I always tell people I have 3 things I'm addicted to in my life: sharks, red wine, and coffee. Maybe not in that order, but sharks, red wine, and coffee, all 3 bring me joy, right? All 3 bring me joy. Kitties, kayaking, grandkids, beer. Yes, we love beer. Ooh, golden doodles, a specific dog, but yes, absolutely, right? I want you to think about something. As you read through this list, do you find yourself smiling? Because I always find when we start talking about what makes us happy, what brings us joy, and we start reading things from other people, man, it just brings a smile. It brings a smile to our faces because we start to think about all the happiness, all the joy. What if I told you that that's all you need? All you need to trigger yourself into a better place, a better state of mind, is just to focus on something happy or joyful. And what we know is that 5 minutes of joy can give us about an hour of productive energy. Think about that for a second. 5 minutes of joy, that's it, gives us a whole hour of productive energy. Why? Because it shifts our perspective, shifts some of those hormones in our body, and gives us energy. So if you could find time in your day, especially on a rough day, to take 5 minutes and take a little, what my clients call a joy break. Take a little joy break in your life, wherever you're at, whether you're at work, whether you're at home, whether you're with your family, whether you're out on vacation, wherever you're at. If you took just 5 minutes a day to have some joy, to trigger your own happiness, I bet that number from that pulse check would shift. And in my experience and the people that I've worked with, it usually shifts at about 2 points. So let's say you're having a 3 kind of day, right? Which happens. We have bad days. We have rough days. We're having a 3 kind of day. We're feeling the 3, but then we take 5 minutes and we go on a walk outside, breathe in that fresh air. We stand in that sunshine, maybe see some of the flowers that are out there, maybe stop by and pet some of the puppies, right? Like we take 5 minutes to do something that just triggers the joy. We come back and all of a sudden that 3 day feels more like a 5. We're reminded of the good. We're reminded of the positive. We've shifted our number. 5 minutes of joy equals 60 minutes of productive energy. So you can have more energy in your day. You just need to find more joy in your day. And I think sometimes people think in order for us to have joy or have happiness, something big has to happen, right? Well, when I win the lotto, I'll be happy, right? Or when I get done with this to-do list, I'll be happy. There's always this, when this happens, then I can, right? I call that an if-then life. If this happens, then this happens. Right? When this happens, then this happens, right? But does that mean you're always waiting to be happy? Right? Does it mean that we're just sitting around waiting for happiness to occur, as opposed to triggering it ourselves? You just made a list, right, of things that you can do to trigger your happiness. So why not look for those things any given day? So I will tell you my joy breaks. I have a sticky note, right? And it has my joy breaks written on them. These are all the things that bring me joy. It's kind of fun to have that list. You post it up on your computer, right? And you look at it every day when something goes wrong, right? You look at it and go, okay, here's some things that bring me joy. Here's some things that pick me up. I'll tell you on mine, dance breaks. I love a good dance break. I was a dancer in my previous life. You can put on some music. I can dance it out. I'm already feeling better just doing this right now with y'all, right? So a dance break is on mine. Music is on mine. Plan my next vacation. Do I have any other planners out there that planning the vacation brings them happiness? If that's you, tell me in the chat, because that's me. Planning the vacation brings me happiness. The vacation also brings me happiness, but planning it makes me feel so excited and anxious and ready, right, for this amazing adventure. So I'll plan it the next vacation for 5 minutes, right? Tammy says, yes, I love it, right? Looking, calling a friend, right? Calling a friend can bring you happiness. For some people, maybe it's looking at TikTok videos. I don't know. That could be happiness, right? If you put that list together of things that bring you happiness, so you stick it to your computer or stick it at your desk or stick it on your mirror in your bathroom, you're going to look at it every day. You're going to trigger your own smiles. How fun is that? We get to trigger our own happiness and make our life better. And we didn't really even have to do anything except look at a list. And that's the truth. It's about looking at the list, reminding yourself these things bring you joy, and then finding time to do them in your day. And I, on my calendar, plan out joy breaks. I usually do one kind of mid-morning, one right after lunch, because everybody needs one after lunch. We just ate, right? One middle of the afternoon, and then one towards the end of my day. I try and put in 4 a day. 4 5-minute breaks. It's literally 20 minutes. That's it. It's only 20 minutes. So those of you that are like, Stevie Don, I'm too busy, I'm overwhelmed, I'm going to tell you, I know, so is the rest of the world. It's all good, right? You have time for 20 minutes. I promise you, you spend more time than that just walking to the fridge to remember what you were supposed to get out of the fridge, right? So we all have 20 minutes in our day. I want you to take that one, you break it up into 5-minute increments, and I want you to do 5 minutes of joy. And I want you to see how that shifts your perspective, shifts your resilience, because you're going to bounce back so much faster when you can tap into that joy in a moment's notice. You don't need anybody else. You don't need anything to happen. It's not an if-then time. It's just, it brings you joy, you tap into it. And I think it's such a powerful strategy for us to use. Okay, so we can do emotional reframing. We can trigger our own happiness. Let's go to the third one. So I did tell you that I love sharks, red wine, and coffee. So sharks are my Patronus, right? When I wave my wand, a shark comes out because I love sharks. And I've learned so much about sharks over the years. I even got to go cage diving once. Amazing experience. But here's one of the things that I learned about sharks that I think speaks so highly to emotional resilience in humans. A shark has to swim or it dies. It's literally the movement through the water rushing over the gills is how a shark oxygenates its body. So literally, if they don't keep swimming, they lose oxygen and they die. I mean, I oftentimes think, gosh, if I had to actually be moving to breathe, how different would my life look, right? Because I personally am one of those people who can just be lazy and watch 8 hours of Netflix, right? So I'm that person who can just, since I can sit here and breathe, I don't have to do anything. Imagine if we were more like sharks. Imagine if the only way we got oxygen into our bodies was if we moved, if we actually did things. And so one of the things that has taught me over the years is just this element of we have to keep going. We have to keep moving. Life is going to get hard. Gosh knows it has been hard for me the last couple of years, right? But I can't give up. I can't stop swimming. I got to keep moving. I got to keep breathing. And so whatever some people like the word mantras, affirmations, whatever your mantra, whatever your affirmation, whatever is the thing for you that you need to say to keep going through the hard days. I know some people who say things like, you know what, but tomorrow's another day. I'll get through today and I'll get to tomorrow, right? Some people say, oh, just keep swimming, right? Very, very infamous from the Finding Nemo movies and Dory. Of course, for me, I think of sharks, but just keep swimming, right? Keep going, right? Rest, don't quit. All those kind of mantras and sayings, if you can find one that works for you, perseverance is resilience. It's about getting knocked down, but saying, I'm not quitting. I'm going to keep going. I'm going to keep fighting for my life, for my success, for my dreams, for my health. I'm going to keep fighting for my health, right? Just keep swimming. So that's my mantra. That's one that I use, but I put it up here as an illustration to you. Find yours. Find the thing that helps you to keep going. Maybe it's just a picture of your family. That's what keeps you going. My family needs me to keep going, right? But when we get stuck, right, down in the bottom where things are tough, we need something that gets us to keep moving, keep persevering forward. So mantras for me work really well for that. Just keep swimming is my favorite because it reminds me of that idea of the shark and just keep swimming, right? So we have emotional reframing as one strategy. Second strategy we talked about was taking joy breaks, right? Triggering our own happiness. Third strategy is perseverance. You got to persevere. That's the only way this works is you got to persevere. Let's go to our fourth strategy. Our fourth strategy is compassion. Now, this one's a little interesting because I think it really happens in two different elements. I think you got to have compassion and grace for yourself and compassion and grace for others. And I want to talk a little bit about this because I think they're words that we use all the time, but do we actually know what we're asking for? So when I say grace and compassion, this is what I mean. Grace is understanding I don't get everything right on the first try. I hate to admit that about myself. I am a perfectionist, right? But I don't get everything right on the first try. So giving myself grace is letting myself know it's okay to not be perfect. It's okay to mess some things up. It's okay to get some things wrong, right? Give yourself grace for that, right? Allow yourself a do-over. Compassion then is saying, and I understand that that happens, and I understand that people go through things. And what always comes to me when I think about compassion is patience, right? We got to allow people some time. We got to give people some patience, including ourselves. And having compassion for that life experience is important. Having compassion for your body is important. Giving yourself grace when it doesn't do everything you want it to do is important. And so when we look at this idea of resiliency and how do we bounce back our emotions, we also then look at this idea of how do we have grace and compassion for ourselves? How do we give ourselves grace and compassion? How do we be our own best, biggest fan instead of our own worst critic, right? How do we focus on giving ourselves grace and compassion and patience to move forward? And I want to speak to the patience thing just a little bit more because I think it's something within my research on emotional intelligence and emotional resilience. One of the things that I learned is that recovery time for emotions is a real thing, right? There's this element of the best we can hope for is a one-to-one, which means for every 1 minute that you experience an emotion, it takes you an equal minute to recover. 1-to-1 ratio. For every minute you experience an emotion, it takes you an equal minute to recover. So let's say you have a bad meeting, you have a bad event, and you're upset for a good 20, 30 minutes. Are you going to be able to just get up from that, walk into the next room and go, I'm good now? No, it's going to take you another 20, 30 minutes to recover. That's part of it. So you got to give yourself that patience to process those emotions. Now, I said the best we can hope for is a 1-to-1 ratio. Some emotions take longer to process than others. So sometimes it's for every minute you felt guilt, you might need 5 minutes to get over it, right? Every emotion is a little bit different, but emotions have to process through our bodies. And so we have to give ourselves patience for that. We have to give ourselves grace and compassion. And one of the things that's been really on my mind as we enter into 2022, I cannot believe it is March already. Where is the year going? Craziness. 2020, rough year for some people, a lot of people. 2021, not that much better for a lot of people. So is everybody feeling better right now today, magically, because we're in a new year? No, right? If people struggled for 9 months or a year through depression and stress and anxiety, they're not going to just magically be better tomorrow. It's going to take them some time to work through that and process through that. So how are you giving people grace and space, right? How are you giving them the grace, the compassion, the patience? How are you giving them space to process those emotions? How are you giving yourself space? How are you cutting yourself some slack, giving yourself some compassion? I think that's a really important piece as well. Now, the next strategy, right? So that's for yourself, giving yourself compassion, grace, but also giving support to others is actually a huge benefit to you. I kind of call it like it's the gift giving like situation. Have you ever given a gift to somebody and watching them open the gift was everything for you? If you have had that happen, put a 5 in the chat. If you've given a gift and then watching them open the gift, that was everything, right? That was life affirming for you, right? A lot of people, 5, 5, 5, 5, 5, right? Why? Because by giving to somebody else, we reap a reward as well in how we're feeling about ourselves. So I want you to take that same element and think about support. When you take time, when you're having a rough day, when you're having tough times, if you take the time to go help somebody else, you actually will bounce back for yourself, right? If you're having a 4 kind of day or a 5 kind of day, it's not great. If you go support somebody else, you go help somebody else, your number will go up. It's that gift giving idea. Because you're supporting somebody else, you receive a reward from that, right? In terms of feeling good about yourself, feeling a sense of accomplishment, feeling like you're supporting others, all of those things bounce your own emotions back. So if you want to have more resilience, support others. Now, don't support others to the point that you give up your own self-care. I'm a big proponent of self-care. Self-care is not selfish, right? You being here on this conference today is self-care. It's care for you and it's care for people around you, right? So self-care is important. I don't want you to support others to the point of not supporting yourself. But when you're having a rough day, give it a shot. Give it a try. When you're having a rough day, go and help somebody else and see if you're not picked up by the experience. I guarantee that you will be, right? So sometimes it's that supporting others in which gives us our resilience, right? We will bounce back. We will feel better just by helping somebody else. And I think that's an amazing thing. It's such an easy thing to do. I love it. Audrey said, that is the NPF community. And to which Matthew said, drop the mic. Exactly. This is the support and this is the resilience happening right now, right? Through this community and these people. And that's beautiful and that's amazing. Okay, so let's go back over these strategies that we talked about, and then we're going to kind of wrap it up with some questions and a final story and thought. So, okay, so we started with emotional reframing, right? How do you reframe your thoughts to focus on some positive elements so that you get out of that vicious cycle of negativity? That's going to bounce up your number. How do you trigger your happiness? Taking a joy break, allowing yourself to experience some fun, right? Will allow that number to bounce up. Remembering 5 minutes of joy is equal to 60 minutes of productive energy. Number 3, how do you continue to persevere, right? How do you continue to persevere, to keep going even when times get tough, right? When times get tough, we have to just keep swimming. Number 4, how do you give yourself grace and compassion? How do you give yourself grace, compassion, patience, empathy? How do you allow yourself the space to get better, to be okay, right? And then number 5, right? How do you support others? Matthew put, I find helping others and giving is incredibly rewarding. My daughter-in-law refers as the follow. Yeah, it's the love language acts of service idea, right? When your love language is acts of service, you get tremendous benefit out of that, right? Love that, right? So number 5, support others, give to others. So here's what I want you to think about. You got 5 options, right? Those are just 5 things we talked about, right? There's lots of ways we can bounce back and we can have resilience. But I want you to look at those 5, right? I want you to look at those 5 and I want you to choose one. Which of those are you going to try to implement in your life? I want you to put it in the chat. Are you going to try emotional reframing? Are you going to try joy breaks? Are you going to try mantras and perseverance? Are you going to try self-compassion? Are you going to try supporting others? What of those strategies speaks to you? Every person is different. What of those strategies speaks to you? What are you going to try in your life to remember how to bounce these numbers back up? Remembering that if we start in an 8, yes, our number will dip throughout the day, but how do we get it back to that 8 before the day is over? We use strategies like this to bounce that back, to have that resilience. So people are saying joy breaks. That's one of my personal favorites. So I totally understand. Emotional reframing, right? Giving to others. Yes, definitely joy breaks. Just the resilience in general. Yes, awesome. Love it. So here's what I'd like to do. I'd like to give you one more story, one more just inspirational message as we wrap up our time together today. While I'm doing that, if you have questions that are permeating your mind, right, put that on here, right? So if you have questions that are permeating your mind, put those on here so that we can answer those as well, okay? So just kind of take that moment. I'm going to give you a couple seconds to process. I want to give you one more story and example, and then we'll close it out with some questions. I already see some are popping in the chat, Matthew. I appreciate it. Yeah, absolutely. Okay, so one more story to leave you with. So we already talked about miracle dogs and dogs that can't swim, right? So the next story I want to share with you is the story of a speaker I met years and years and years ago when I was getting my doctorate at Colorado State University. We did these leadership summits and they would have these speakers come in and speak to us and all these things. And so the speaker went to the front of the room and he held up a $20 bill, right? Held up a $20 bill. Now you can imagine we're all broke grad students, right? He goes, okay, raise of hands, who wants it? Every single person in the room, right? Raise their hands. Who wouldn't want this, right? Every person wants it, right? Cool, he takes it, crumples it up into a little ball. Who still wants it, right? Everybody's hand's still up, right? Everybody still wants it. He takes it, he throws it on the ground, he stomps on it, tears into it with his heel, and it comes up looking a little ratty, right? He says, who still wants it? Some hands come down, but most of the hands are still up in the air. He said, very good. You just learned a very important life lesson, because life is going to crumple you up. Life is going to dig into you with its heels. Life isn't fair. It's not going to be great. And sometimes you're going to have to do things you don't enjoy. But what you always have to remember is that no matter what life does to you, you still have value. You still have worth, just like the $20 bill. And that story has always stuck with me to the point that I actually I've had this $20 bill for years. It's pretty old and wrinkly. I keep this on my desk. I keep it as a reminder about resilience, because one of the key tenets of emotional resilience is believing in yourself, believing in your worth, believing in your value, no matter how much life drags you down. And I keep it as a reminder to myself that I always have worth, I always have value, no matter how crumpled up I feel. And I would encourage you, if that story spoke to you, it doesn't have to be a 20, put any kind of dollar bill at your kind of workstation or by your bed, and you'll remember that. And that is part of resilience as well, right? So I just wanted to share that story with you. Very impactful for me. All right, let's get to some of these questions. Okay. Oh, I love this, Audrey. Supporting others. Voluntesia. That moment when you forget you're volunteering to help change lives because it's changing yours. I love that, Audrey. That's beautiful. Okay, Matthew had a question, and I preface it by saying, I love all your enthusiasm and strategies. Well, thank you, Matthew. I appreciate it. What do you feel are the red flags that you look for in individuals? Should we look at those in ourselves? Oh, when one should get professional psychological help? Oh, that's a great question, Matthew. Thank you for that. So here's what I notice, right? I always, number one, I am a coach. I am not a counselor. I am not a therapist. And I make very clear that delineation in my own practice and in my own business, right? So I do life coaching and business coaching, personal coaching, but I don't go to that side. For me, the red flags I typically look for, because I am one who will recommend that to my clients, say, hey, maybe it's time that you see a therapist. I think that would be helpful to you. Here's the red flags for me, right? The red flags for me are things where either you become so stuck in the negative emotions that even when good things are happening, you can't see them. When you can no longer acknowledge the good because you're so stuck in the bad, that's a signal to me that we've gone too far, right? I've been there myself, so I speak that from my personal experience. There was a time in my life where I was so depressed that even as things were going good in life, I could not see them. In that moment, I knew I needed professional help, right? I needed to go talk to somebody who could help me unpack whatever the trauma or healing was that I needed, right? So I look for that. That's one of my red flags. Another red flag is just time, right? It does take time to process emotions. It does take time to get over things, but I think all of us can kind of set ourselves an amount of time that feels okay versus an amount of time that feels excessive. Right? Now, I set that for myself. I don't let other people set that, right? So let's say you're going through something traumatic in your life. You're going through a divorce, right? That's going to impact you differently than it impacts anybody else with divorce, right? It's a personal thing. So some people around you may say, well, it's been a year, get over it. Well, maybe for you, you need longer than a year. But I always encourage my clients to do that self-awareness check and ask yourself, okay, but am I feeling like it's going on too long? Am I feeling like I'm stuck and I'm not getting out of it? That's another moment where I say, okay, when you're just so stuck that you're not getting out of it and you realize it's been too long, that's another moment with which I would say seek professional help. And then the third thing I would say, and this is more just a delineation between coaching and therapy, right? Coaching doesn't really handle trauma, right? Coaching is not healing. Coaching is encouragement, right? Within like a life coaching space. So I always say, I'm here to support you. I'm here to encourage you. I will be your biggest cheerleader. I will help you remember your greatness. That's my work. But I'm not necessarily capable of healing any abuse or trauma or things you experienced in your life prior to meeting me. while I can give advice, I'm not a licensed counselor or therapist. And so I always tell my clients, like, we're on the moving forward train. If there are things you need to heal and deal with from the past, those are things I refer out for, because I just think that is not my space. And I definitely do not want to do any damage or any harm. So for yourself, are you in a space where you're looking to the future and you're saying, I just need some encouragement and some growth? That's resiliency, and you can bounce back using a lot of the strategies we used here. If you're really talking more about how do I heal from things that have happened in the past, that's more than resilience, that's healing, right? Resilience is bouncing back like a ball that you're dribbling and it comes back up, right? Healing is a different mode and a different place. So if you are in a place where you just need the bounce back, that's resiliency. If you need the healing, that's a different, that's seek more professional help on that side. I hope, Matthew, that clarifies that question. So that is kind of hard, right? To think about where is it just be resilient and where have we gone too far, right? But those are some things that I use, and those are the suggestions I give to my clients. So hopefully that clarifies it a little bit for you. I think the big thing is to always do those self-checks. Do that pulse check on yourself every day, every night. And if you feel like that number is hanging around a low number for way too long, step up and ask for help. And that's hard, but it seems like you have a really supportive community here to help you. So I think that's a really great place to start. All right, I'm going to put my contact information up on the screen. If any of you, if I can ever support you, if I can ever encourage you, if I can ever help you in any way with resilience or otherwise, please reach out, please contact me. I am here to help. And that's my whole goal in life is to help people make their lives better. So if I can help you at all, I would love to do that. So thank you so much for allowing me to be here. Thank you for allowing me to be a part of this community, even for the short time that I'm here. Thank you for your engagement in the chat, staying engaged, staying involved. It's so helpful as a speaker to have people do that. I truly appreciate it. Thank you to Audrey and the team for having me. And with that, I will turn it back over to you all. Thank you so much.
Thank you, Dr. Stevie Dawn. That was amazing. Thank you. So we are at another break. So let's go ahead and take a 5-minute break and stretch, grab another drink, grab another snack, and we will return. And again, if you have any questions, go ahead and put them in the chat and Audrey will get them out so we can get them answered. We'll see you in 5, you guys.
Well, we're about done with our break. So Jen, are you ready to kick us off for the last part of the conference?
Yes, I am. So, see here. So without further ado, my favorite part for NPF advocacy, I am happy to announce the new arrivals to NPF advocacy, Will Hewert and Jason Harris. Welcome, you guys, and thank you for what you're doing.
Thank you, Jen. And thank you to all the previous speakers, Dr. Murase, Dr. Rieder, and Dr. Don. Those were all really informative and great sessions. And I know I learned a ton. Just other thank yous. Thank you to Jane, Audrey, and the whole NPF team for inviting Will and I here to speak today. As Jen had sort of mentioned, we are a little bit newer as an advocacy team here, and we're really, we're very energized and looking forward to build on a ton of the previous successes of all of you as NPF advocates and the NPF advocacy team. I wanted to sort of start out just as a background, just so everyone knows sort of how our team is structured, but we have three folks, one that covers the West, one that covers the Central, and one that covers the East, all those different regions and all the states there. So that's just to say, whatever state you're in, we have someone who would love to work with you. And sort of as we, dive into a little bit more about what we do, I just wanted to flag that so you know that, there's definitely someone there who would love to chat further about anything you might be interested in. And I wanted to start out too, one of the things that has been impressed upon me in my relatively short time here, other than how great our NPF staff has been and sort of welcoming and the culture we have, but the commitment and passion of NPF advocates, both in the previous accomplishments that I've seen from afar in previous work I did, but then also looking forward at the outlook of the future and sort of the passion to keep pushing to do more is again, it's something that's really energizing as a staff member here, because there's no way we can succeed, as a staff without all of you. It's kind of like that old JetBlue advertising slogan, something to the effect of, we would just be, without you, we'd just be a bunch of blind TVs. And so I think that really, it goes very well here, because we know that without, your voice, your story, nothing we do is going to come close to success. So we can go to the next slide, and Will, who's on as well, he'll take some of the slides following this one, but I wanted to give a nice introduction and then talk a little bit about what advocacy means to us. We just go to the next slide. Sorry. Thank you. So what is advocacy? I think, you see all the handshakes here and all of obviously pictures from previous work, but at its core, it's all about relationships and building relationships. And so, I think what we're here to do as NPF advocacy staff is ensure our leaders in Washington and those across the country understand the impact of psoriatic disease on our community, and most importantly, how and what they can do to help. So as I mentioned before, I think there's been a ton of success from this community already. And it's really impressive to kind of come in and be able to see all the things that have been done. It also, gives us that inspiration that we can continue to build on that and use those relationships that we have already to kind of take it to the next level. So some of the things we can do are leveraging the U.S. government to increase research dollars towards our cause. And the federal government and the National Institutes of Health are really the leading funders across the world in terms of the amount of money that they provide for research at the basic level. So being able to, again, leverage our relatively small resources compared to that, and then take it to the Fed and try and do different appropriations programs, or just generally work with the NIH and sort of the subdivisions about folks that may focus on psoriatic disease is critical. And that's one of our aims all the time. Another thing we do is working internally with our PNC team to identify problems that are facing the community, and then work to protect critical access to care issues that we can discuss at length after. But I guess with advocacy, there's the obvious, let's go meet with our member of Congress, but there's also a ton of other things that I think fall under the advocacy brand. Things like working with our research team to help our industry partners and regulators like the Food and Drug Administration understand what's most important to you about a treatment. What are the things that you want to see in a treatment, a newer treatment, or how do you best want to manage your treatment? And some of those things don't always come out in sort of the scientific literature. So having that patient perspective, that your voice about what's most important is really important. And there's been a huge shift in evolution and sort of thinking. So that perspective is actually only more influential as we move forward into the next decade. And I will say, in terms of some of the agencies we work with, obviously there's the administration, the White House, federally, that is members of Congress, both in the House and the Senate. And we want to help, them understand the impact of this disease and then how they can help you as their constituents. We also work with different agencies like the Human and Health Services, Centers for Disease Control and Prevention, the Food and Drug Administration, as I mentioned earlier. So trying to understand what the priorities of all of these different agencies are and how can we best fit in and work with them to ensure that our cause and the people that we're supporting are front and center in that, and that we can also align our programs so we're all moving towards the same direction and there aren't duplicative efforts and sort of wasteful efforts in that sense. And then lastly, we also have we work with other partners in the patient advocacy community. There are a lot of others that are facing similar issues, and so being able to partner with them and then collectively put our voice together is also a really powerful thing. So whether that's other patient organizations, certainly our providers and provider organizations, and then our industry partners, health plans, we want to work with everyone. We don't see anyone as outside of our community. And obviously there's going to be different areas where we'll disagree or we will agree, but we think that as long as we can work with everyone in a meaningful way, that is a really, really important thing to do. And I think NPF specifically has done a really good job of doing that and being able to interact with many different groups and in some cases non-traditional partners to be able to to maximize the impact that we have. And I'm going to stop here and I'm going to invite Will to join us. He's going to walk through a couple other specifics, maybe some items that we have for this year, and then I'll be chiming in as we go. But just wanted to say thank you also for everyone for joining. I know it's a Saturday and we're really excited to be here. So Will, take it away.
Yeah, thank you, Jason. And like Jason said, I'd like to thank all the previous speakers and Jane and Audrey and all the great people organizing the conference for inviting the two of us to speak. So I'm going to talk a little bit. Jason gave us the big picture overview of, who we are, what we do as a department. I'm going to talk a little bit more about the nitty gritty and also about how you can get involved as a member of the community. Because something that I think is really important that Jason touched on is we really, really can't do any of this without your voice. I think sometimes we talk about advocacy in a way that makes it sound intimidating, like it's Mr. Smith goes to Washington or you need a law degree to even get started. There's nothing further from the truth, right? The policymakers, some of the hotshot corporate lobbyists, they're the ones who have gone to school for decades, who do this for a living. Legislators know that's not necessarily what you're going to be, though you can certainly have that background. What they want to hear from you is how these abstract, very confusing pieces of legislation will actually affect you in your day-to-day life as a person living with a chronic disease. And no one is more of an expert in their own lived experience than you are. And so you have an invaluable perspective to share. Here's why this law affects me and my broader community. And that's not something that Jason can do or I can do alone, right? We can only talk in hypotheticals. You can actually talk about the real life effects of this. And that's why it's so, so important that we really work with you to make sure that you're leading the charge and intimately involved in this work that we do. So with that out of the way, I want to talk a little bit about a few of the areas that the advocacy team works in our sort of day-to-day work. So our main sort of prerogative, our main goal is improving access to care, whether that's reforming utilization management practices that make it more difficult for people with chronic illnesses to get their medication, like step therapy and accumulator adjustment programs, whether that's reducing out-of-pocket costs. So even if you do have your medicine covered, it might be unattainably expensive, making sure that the robust protections we've seen for pre-existing conditions in the last decade and a half or so don't get rolled back, increasing research funding. Like Jason said, we know that these research dollars have led to innovations that make a huge difference for this community, and we want to protect that investment and grow it, and more, because it's sort of a truism, but you never know what's going to happen in Washington, right? There's always something different. There's always new issues that come up, and part of our team's job is to stay in touch with the PNC and with all of you so that we know when new issues are coming up, and we can see when Washington or state capitals are considering issues that might affect this community's access to care. Next slide. So we sort of, as Jason alluded to, we operate on two levels. We do state advocacy and we do federal advocacy. And we have sort of an AD who does federal advocacy along with Jason, and they're really looking at what's going on in the crazy world of Washington, following those big picture bills. And then in the states, the laboratories of democracy, we have 3 people broken down into regions, as Jason mentioned, overseeing different states, and each one sees about 15, 17 states or so. And as you can see from these pictures, we like to meet directly with legislators, get patients and community members talking to them, sharing their story, talking about why these bills would make a difference in their lives. Yeah, I agree, Audrey. There's lots of familiar faces in these pictures. And you'll notice that's a theme as we continue. It's obviously been a bit harder to do these sort of face-to-face meetings with COVID, but I will say the previous team before Jason and I came on did a great job of finding ways to do that, whether that was virtual meetings, whether that was defaulting back to letter writing and email writing. There's lots of ways that you can be involved in a very direct way, even without getting all up in someone's face, within your 6 feet bubble. And I think that our team has done a great job of rolling with the punches and making sure that we can still be effective in meeting with legislators. And, one thing that you'll notice as a trend is that some of the same issues are addressed at both the state level and the federal level. For instance, step therapy, which I'm going to talk about in a few slides. Almost 30 states, or it may even be 30 states now, have passed legislation sort of creating guidelines or restrictions on the use of step therapy protocols. But there's also a piece of federal legislation that would address this issue at the national level, not only in those 30 setting out clear standards across the country, but also in the 20 that haven't seen any sort of restrictions put in place. So these are equally important because even though the federal legislation might have a broader scope, things also tend to move slower in Washington. And so we like to be engaged on both fronts because there's always wins to be gotten, right? No matter what sort of level you're talking about. And that's been really key to our success so far. Do you have anything to add on that, Jason, or next slide?
You can go to the next slide.
All right. So, like I said earlier, if I went through sort of all the issues we deal with, copay accumulator adjustment programs, step therapy, non-medical switching, Medicaid, we would be here all day, frankly. And I know that you guys, as Jason said, are doing this on a Saturday. I don't want to take that much time, especially because we have an advocate panel at the end of this, so you can hear some of our advocates speak. So I'm going to zoom in on one access to care issue that our team has had a lot of success with, which is step therapy. Step therapy, which is also sometimes known as fail first, is a practice in which an insurer will say that you need to try and fail off a different medication that hypothetically covers the same thing before you can fill a prescription that your doctor gave you. And often that's because they have a better rate at the medication that they prefer. And so their thinking is, well, these medications hypothetically do the same thing. Why don't you try this one first because it's cheaper for us? And then if it doesn't work, we'll let you try the medication that your doctor's prescribed. Now, we understand the use of step therapy. We know why insurers are doing it. We understand that it has some place in sort of our broader healthcare system, but some of the ways that step therapy is implemented make no sense. For instance, you can be put on step therapy for a medication you've already tried before, and it hasn't worked for you in the past, but you did it with a different insurer, or even the same insurer in some case, before the policy was implemented. And so they're like, why don't you just try that again? Sometimes you get prescribed a medication that in theory should be identical, but you might have some sort of complication or even an allergy, or your doctor knows for a fact it's not equivalent in your specific circumstance, and you'll still be put through the step therapy protocol. So really at the end of the day, our position is that doctors and patients should be the ones deciding standards of care. not so much insurers. And so we support protocols that create guardrails or workarounds for step therapy, in which if you are put in a step therapy protocol that your doctor and you know for a fact won't work, there's a clear system to appeal that, where you can get a response in a timely manner, and there are consistent standards for when step therapy can and cannot be applied. And we've been very successful in convincing states to adopt these reforms because, you know, they are common sense. Even lots of the insurers will sometimes, when they hear about this, say, oh, we didn't realize that this was a possible outcome that could happen with these step therapy programs. So as I said earlier, we've passed or seen step therapy reforms passed in almost 30 states. And this map is out of date. It's not even that out of date, but things have moved so quickly. There are several states on here that are not a deep blue or a light blue that now have step therapy laws either on the books or already in effect. But I used this image because it had really great images of several meetings that the previous team arranged with legislators, which we call Hill Days, in which members of the community in any given state sort of descend on a state capitol and meet with their legislators and talk about, you know, why this step therapy bill would help them get access to their medications and why having these guidelines on step therapy on the books is so important. So you can see, you know, for instance, we've had meetings in Texas, in North Carolina, in Washington, Massachusetts, California. Again, if we zoomed in on all these images, I think you would see a lot of familiar faces. You've done this call today, see if you can spot yourself, just as a fun game. But what I think is so important about this is, like I said earlier, lots of people can talk about the nitty gritty of the bills, right? The fine print. It's section 2A changes an is to an are, but only if the co-assignment forms have been done by October 22nd. All that sort of language, you know, I frankly can't read a lot of it. I leave that to Jason. But even the people who can read that very well, what they can't always know is how will this affect someone who might need to choose between, you know, getting enough groceries and affording their prescription, or what could happen to someone if they were put on a medication they know for a fact won't work for 5 months. These are elements of the implementation of the law that legislators don't always know about. And so that's why it's so important that these meetings you see in these pictures happen, right? Because this is where they learn about this side of access to care and where they learn why these bills really do matter to this community.
Well, let me just taking a step back too, because I think, you know, and as I'm not gonna call myself an outsider, but coming in and sort of taking a look at in 2015, 2016 is really when this issue started to pop up. And so as an advocacy team, you know, really what happened was, you know, the community came NPF was starting to get messages about, you know, this was an insurance problem that was occurring, right? And so NPF as staff and as an organization took the time to, you know, see who else this issue was affecting, right? Started to build a coalition of other partners, which ended up turning into something called the Safe Step Coalition, which has over 50 patient advocacy members, patient advocacy organizations and other members to this day, and came together. So, you know, having that collective voice to be able to have a, you know, a much larger impact in that sense, then also activated our staff on the state level to start getting those stories. And of course, this is all not possible without people, you know, people living with psoriasis and psoriatic arthritis to come together and share our stories or share their stories with us. Then we can then, you know, kind of help, you know, tutor and basically get folks to speak at those state houses, meet with their legislators. And so just within the last 6 years, right, 30 of the 50 states in the states have passed legislation to protect that. And that really is an incredible accomplishment. Like, I think that sometimes is a little bit underrated, and maybe it's because this community, you know, you've already seen it and you've done it, but when you can take a step back out, that is enormous. And obviously it wasn't done only by us, but NPF had a significant leadership in that space. Yeah. And so this is also something that has helped. I mean, there are many other conditions that step therapy affects. So to be able to come together and really have that impact and really be able to help so many people, I'm always astounded when I think of that. And to Will's point, we also have federal legislation that hopefully can take care of, you know, the other 20 states if we're able to get it passed. But even that legislation has a ton of support in Congress, and, you know, for a variety of reasons, certain bills aren't moving. We can talk a little bit more about why DC can be DC, but I think I just want to stop here and really say, like, when you can take a step back and think about it, the impact that a community like this has been able to have is really incredible. And I think we can replicate this as we move forward, looking at other issues. So I'd just say, like, kudos to everyone who's been a part of it. And if you haven't, there's other issues that we want to start to tackle, including step therapy. We're obviously not done. We're continuing to work on this because it is something that, unfortunately, we still do see in certain areas. So I just wanted to kind of put that color commentary on it, because it's kind of a unique case study in how advocacy can be really successful. And that also goes, we've been meeting with some of the federal agencies, whether that's CMS, HHS, and writing comment letters to sort of help them understand some of the problems there as well. Just so it's, we're hitting them from every side, so that hopefully in the next few years, we can see that be 50 of 50 or have that federal legislation passed. That's certainly our goal. So keep going, Mo.
Yep. No, that was great context, Jason. Thank you. I will say I'm slightly less of an outsider in the sense that I did advocacy as a person with a chronic condition in a different community before I came here. And I can absolutely confirm what Jason is saying. The condition I have is very much affected by step therapy as well. And as a volunteer, as one of the people in these meetings as a patient rather than a staff member, I absolutely saw that NPF was taking the lead in this space, and that the volunteers of NPF were very much involved, always testifying when there was a bill up in the State House, always putting up letters when regulators or state Medicaid or whoever asked for comments, not just on step therapy, but on a host of issues that we share in common. So I absolutely want to echo this. It's not just inside NPF, but outside NPF that this community is known as leading the charge on a lot of these issues. So next slide. So like I said earlier, we want to deal with this on the states because sometimes it's easier to pass things in the states. As Jason perfectly put it, DC is DC. But there's also ambitions to address this at a federal level, right? Which would save people a lot of headache. There's those 20 states still out there, right? And then even within the 30 states that do have step therapy regulations on the books, they're not all the same sort of restrictions, the same sort of protocols. And so it's sort of a patchwork framework. And so we'd love to see sort of a clear standard across the books so that a doctor moving from one state for another, for instance, doesn't have the wrong idea about when they can or cannot appeal step therapy. Because even physicians, they might not spend all their time thinking about sort of the regulatory framework at the state level on these issues, especially if it changes month to month or year to year. And so having something clear in place across the books would just give us a lot of peace of mind. So to that end, we have the Safe Step Act, which would basically clarify when insurers can and cannot implement step therapy programs. This is a piece of legislation that's been introduced in multiple Congresses and fallen short several times now, but it just keeps building momentum. And so all we can do is continue emphasizing why this legislation is important, the difference it would mean for our community and for others. And the good news is that this bill does continue to gain momentum. So this year, our bill numbers are Senate 646 and House 2163. Last Congress, the bill had 158 co-sponsors in the House and 19 co-sponsors in the Senate. I believe on the next slide, there are numbers for this conference or this Congress, hopefully. If not, I do not know that I remember those off the top of my head. Let's see. Oh, nope. So I will say I don't remember them exactly, but I believe in the Senate we have more co-sponsors, but in the House we're not quite yet up to 158, which doesn't mean that there are representatives who have switched their position. It just means that 130, oh, thank you, Jason. Jason bailing me out as always. So yeah, you shouldn't look at that 130 and say, what about those other 28? Because there's tons of bills in any given Congress. Sometimes representatives forget about them or need the extra nudge to sign on to them. So all that means is we just need to continue building momentum, continue reminding them about these bills and why they matter. So just very briefly, now that we've sort of talked about step therapy and how it's been addressed at the state and federal level, I want to go through some other issues that affect out-of-pocket costs that we focus on. So at the federal level, we're very interested in the Medicare Part D out-of-pocket cap, and at the moment, the lack thereof, right? We want more clarity, sort of setting out clear limits on how much a patient can be charged for prescriptions under Medicare. And at the moment, that's a real burden for some patients, and we just want some more guidance and clarity on that from the federal government. We're also interested in copay accumulator adjustment programs, which is a huge mouthful of an issue. Copay accumulator adjustment programs are essentially utilization management program in which an insurer takes your copay assistance that you might get from a third party, such as a manufacturer. They take that money until they run out the fund, and they turn around and say, yeah, we're not counting that towards your cost sharing obligations towards, a copay or a catastrophic limit, anything like that. And so patients who think that they're getting these huge bills paid with their assistance find that the assistance money has been accepted, but it hasn't been counted towards their actual obligations before different levels in the insurance actually kick in. And again, this is a problem that we've seen some success dealing with at the state level, but there's also legislation currently in this session of Congress to deal with it at the federal level. So oh, sorry.
And I was just going to say one example of sort of some of the state advocacy and things that we've done. And Tammy, I know you're on, but Tammy wrote an op-ed in a local paper in Pennsylvania about this issue that had sort of detailing why it was a problem. And so, even little things like that where we can work together to kind of boost your voice and connect with the local papers. Tammy obviously sort of took a leadership position in all of this, so we really thank her for that. But there's a virtual advocacy day coming up in Pennsylvania, and so we want to get Tammy kind of linked in there because she's already got this great op-ed about what this problem is, and so it kind of just continues to set the tone, and it makes it, I don't want to say easier, but it makes it even more powerful, right? That a newspaper sort of put this out there. She's obviously really engaged advocate, so when she goes to that meeting, she's going to be even more prepared to make an impact. And she is incredible. And this issue, I saw a chat was there before. This issue has been going on for too long, and we agree. Even 1 week is too long of it, and so it's definitely a serious priority for us. And I think you'll see that as we continue to talk more about it and see some of our priorities for Capitol Hill Day coming up on one of the next slides.
Yeah, no, that was great. If you could go back very briefly, there's just some information about state info. So on the state level, we're dealing with copay accumulators again, like I mentioned, non-medical switching, which is an insurer changing what's covered under their prescription formulary in the middle of a plan year. You think your medication is covered and all of a sudden you find that it is not. And finally, 1115 waivers to adjust state Medicaid programs. So those are just a few of our issues. And Tammy's saying she had a lot of NPF help. She's being modest. She wrote it. We took a look. We were like, yeah, that sounds about right. Got in touch with the rest of the coalition that was helping getting it published. And yeah, I just want to emphasize what Jason said. There's lots of ways to get involved and use your voice and your story to make a difference. And writing an op-ed is absolutely one way. We're not just, like I said, we're not just doing the Mr. Smith goes to Washington thing.
And I will just say this too. Well, we understand that, you all have your day-to-day lives, obviously everything going on in your personal lives, professional lives. And so with our programs, we really want to make these turnkey, right? We don't want to make anything difficult on you. So any questions, any thoughts, we want to be there to help as much as possible. And I just would reiterate that because as you think about maybe I would like to sort of take another step in this direction, feel free to reach out. We can talk through what some of those processes look like. And again, we want to make this as easy as possible for you. That's our job as staff. And that's something, for me and with our team, as we look at what we're doing, that's an internal priority and something that is really, really important to us.
Yeah, no, that's a great point. Thank you, Jason. So now next slide. So I want to turn it to Jason to talk about this, if that's okay, but not putting the spot. But one of the big things we do is our Capitol Hill Day, which is one of these Hill days, like I mentioned, but just at the federal level. And Jason's really taking a huge lead in setting out our federal priorities. So I want to turn this to him to talk about this event.
Yeah. So we just wanted to make sure everyone was aware. We're going to be doing our virtual Capitol Hill Day this year on May 10 and 11. You can see that map kind of splits off the geography on which day your state may be in. But I just wanted to flag this for everyone. Right now, we're working through our priorities. We're working through getting our training materials ready to go for our advocates to be able to attend. And we're going to have registration for our Capitol Hill Day coming up in just probably the middle of March, so a week or two. And we're really excited for our whole team. We're really excited to kind of put on our first Capitol Hill Day as a team. But, again, this isn't anything new to NPF. We've been doing this for a long time and had a ton of success. So just wanted to make sure everyone was aware, and we'll be sending more information out and make sure that finds your inbox. So, yeah.
Thanks, Jason. So I saw Lori was asking the question of what will it take to get these accumulators taken care of? And I would love to get more into that, because I agree it's absolutely an outrageous practice. And the good news is there are some things that can be done about it, both on the bird's eye view level and also sort of the ground level use. So at the individual level, you can absolutely work with our patient navigation center to try to appeal an accumulator or find a solution. At the state and federal level, right, these pieces of legislation that we've seen in several states can really do a great job of addressing it. We've passed accumulator reforms in 12 states and Puerto Rico, I believe. So it's absolutely something that we're beginning to see movement, and states are beginning to acknowledge that's a problem, but there's still a lot more to be done until we even get to where we are with step therapy. So, it's a tough issue, but all we can do is keep reiterating why this is so harmful and why it needs to be reformed. And like I've been saying throughout this, we can't do that without you, but when volunteers and members of the community get involved, we really can make a difference in these high-scale policy discussions. So I would love to talk more about that, but we haven't had a chance yet to hear from some of the advocates who have generously agreed to speak on this call this afternoon or morning, depending on where you are. So if we can go to the next slide, I would like to ask, oh, sorry, I totally forgot, interested in advocacy. So we don't just want to talk to, like I said, the amazing advocates who have done stuff with us before. If you want, any of this sounds interesting to you, we would love to hear from you and to talk about how you can get involved, right? Because like Jason said, we want to keep growing this program, make it accessible, make it easy and attainable for people to get involved, because it really, really is so important. So we provide training to learn about the issues. We teach people a little bit about how to tell their story, connect with a lawmaker. All this information and more you can get in our Advocacy Action Network. And there are links to get involved with AAN on our site, and links to get our email action alerts and all sorts of other resources as well. So if anyone has questions about how to get involved, you can reach out to me or to Jason over email. I can't do two things at the same time. It's always a failing of mine, but if someone can type both of our emails in the chat, just drop a line and we'd be happy to discuss this more. So we can go to next slide. So now here we go. I was one slide, I jumped the gun by one slide. So we have two advocates who have very generously agreed to come on and speak a little bit about their experience. So I have a few questions for them that our team has prepared, but I also want to give everyone in the call a chance to ask questions as well. So without any further ado, if Savannah and Jen could come on camera and talk a little bit about their experiences as advocates. All righty. Well, first things first, I guess you both want to introduce yourself very briefly and talk a little bit about how you got involved in NPF's advocacy work. What your journey was to this program and to getting involved with it.
Savannah, do you want to go first?
Oh, sure. Okay. So I'm Savannah. I'm from Houston, Texas, and I am one of the co-chairs for the Central Region for Advocacy, and I'm also a member of the Capitol Hill Day Advocacy Committee. I got involved with NPF probably 4 years ago at this point, I believe, and it's been pretty great ever since. And I've been able to take more leadership roles in it and help get a lot of bills passed, which really helps with I think the frustration that we often feel as psoriasis and psoriatic arthritis patients. And I've had arthritis since I was 14, and I got psoriasis at 18, and I'm 26 now. Do we need to say anything else, Will? I wasn't sure about exactly.
No, that was perfect. That was perfect. I didn't give you much to work with.
Great.
No. Perfect, Savannah.
Okay, so you all know me. I am Jen, and I'm sure if you didn't know who I was before today, but just to give you a little background, I was diagnosed with psoriasis when I was 15, but I wasn't a stranger to it. My father actually has it, and my younger brother also has it. So between the three of us, I am the only one that does advocacy. But as I mentioned earlier, it gives me purpose, kind of like how Dr. Stevie Dawn mentioned, that whole you receive back what you give. I have been somebody who has struggled. I got psoriasis right in the middle of high school. So it was just one of those things where I just struggled with that. And finding the NPF, actually, I found it during a college paper, and I haven't looked back, but I can honestly say the NPF has been such a blessing, and being able to give back and do advocacy, especially like this year, I got to testify on California's Senate floor for step therapy, which we got passed. It's a great feeling knowing that not only are you helping yourself, but like in my case, family members, friends who I consider family, and I'm educating others. I mean, there's a lot of my friends and family that wouldn't know what I go through if they didn't know about this work that I do. So it's one big reason why I do advocate.
Yeah, no, thank you, Jen. That you almost perfectly preempted my next question, which is what's something you've gotten out of your involvement with advocacy. So you beat me to the punch, but I guess I'll put you on the spot by pulling out another thing you've gotten out of it, just because it's been so meaningful for you. To give you time, we can do the same order. Savannah, if you want to answer first, and then we'll go back to Jen.
Sure. I think the thing I got out of advocacy the most, I think, is meeting other people who share the same experiences as me or similar experiences. I had never met anyone with psoriatic arthritis before, but as with Jen, I also have a family history of psoriasis. My dad has it, his sister has it, and one of my cousins have it. So I definitely had enough experience with others with psoriasis, but it was cool to have people outside of the family that I could create community with, talk about the struggles of it, talk about just general med stuff, even the most mundane things. And I also think it helps me work out my frustration. Like I said earlier, it gets pretty tough when you have rejection after rejection for coverage, and you have to try a medication that you've already tried. Like I keep getting told I need to try Humira, but I am allergic to Humira. So a lot of that causes a lot of frustration. And this really helps me feel like I have at least some bit of control over what happens to me in my medical decisions when others are involved.
Yeah, thank you. Jen, I was joking earlier. It's totally fine if you don't have another answer, because I think you answered beautifully before. But do you have something else you want to talk about to this point of like what you've gotten out of advocacy or how it's changed?
Well, you know better than that.
Yeah, I know that you can always talk about advocacy. So yeah, I'll shut it down.
I think, one major thing I think the NPF has given me is, I've been a volunteer at the NPF for 14 years. I didn't always want to be a nurse. But being able to give back, and as a nurse, you're a patient advocate. So already having the advocacy experience and being able to know I'm my only voice, and seeing the frustrations as a nurse with the access to healthcare and stuff like that, I'm also another lifeline to these patients that are able to help them get access to things they need or healthcare that they need, or answer questions. So being able to not only like arm myself with the nursing education, but being able to arm myself with that volunteering and advocacy and knowing that it's all for the better.
Yeah, no, that's a great point. You know, something that I didn't get to talk about in this presentation, but I wish I did, is how advocacy is more of a means than an end, right? We're specifically using it to talk about access to care, to talk about insurance, but really advocacy is all about standing up for yourself and articulating your own needs. And that can take so many forms. And that means that all of you on this call are advocates, even if you don't know it, right? Because we all have to be in day-to-day life. And then especially if you have a chronic condition and you need to have various needs met or things understood by an outside world that might not understand all the time. As a child, my parents decided I needed to do advocacy because I was very annoying, asking for a dog all the time. You know, I would hold my breath. I would write out these little kid contracts in crayon stipulating how much I would walk the dog versus them. And they're like, well, if he's going to be this persistent about it, we might as well use his powers to, you know, bother people for stuff for the greater good. And they took me to the state capitol in Richmond. And I put all those skills I learned from going to Richmond to service of getting the dog, and eventually they caved. But I think that just goes to show that this isn't a scary process, right? It's something that all of us know how to do on some level, and just applying those skills towards a greater good for this community. So yeah, that was beautiful, Jen. Thank you. So my next question is, what's your favorite memory from your time in advocacy? If there's any experience that really sticks out for you in all your years of doing this.
Other than this meeting right now.
Yes, thank you. That's a good clarification.
I'll go, Savannah. So favorite thing about advocacy is, besides the relationships you get to create, I would honestly say being at Capitol Hill for the first time and just knowing that the legislators and stuff like that you talk to, they're listening. Yeah, it stinks that I had to testify on the Senate floor via Zoom, but that was also an awesome experience too. And I will tell you, actually, it was an emotional experience because after you give your part and you speak, you are able to, you hear all the other organizations and you hear all the other support for the bill. And I spoke on step therapy because I've been a product of step therapy, and who hasn't? But just hearing all that support, I actually got emotional thinking like, wow, we're not the only ones fighting for this. It's a team. And just that there was just amazing.
I definitely second Jen's comment about being on Capitol Hill for the first time. I didn't go until I was 24. I think it was literally right before the pandemic hit. So I got in there pretty quickly, and it was pretty awe-inspiring. I don't know. It's a weird feeling, but it's really, really exciting to be able to stand where policy is being made and contribute to what your representatives and senators and other legislators and functions of the government who you can talk to and be like, here's how it is. This sucks. Here's how to fix it. Help support this bill. And people that I never thought would agree to supporting certain types of bills have, with my senators, Ted Cruz and John Cornyn. I often don't think we're going to get much done. And I'm always surprised, especially with Senator Cornyn, that, you know, he is looking forward to making changes in healthcare access and trying to lower the price of drugs and help patients avoid a lot of issues that we have to deal with today. So I think that is probably one of the most rewarding ones, because I'm not, yeah.
Yeah, no, that was great. And I want to jumping off that a little bit, it really is something you realize when you meet with legislators or with their staff and their aides, is you'll talk about an issue, right, that you've come before them about today. And they'll say, tell me more about that. I didn't realize that this was a problem. I didn't realize this was something that could happen. And I really have come to believe that, you know, part of why NPF has been so successful is we're not about politics so much as policies, right? We go in saying, you know, we know there's more stuff going on in the broader world of Washington, but we're here today to talk about how this affects us. And you really will find when you explain that and you bring the human essence of it, right? How it affects people, that lots of people, once they understand that, are willing to work with you and to find ways to go against the grain of what their party might be saying, or to, you know, find compromise and bipartisanship. It really is a powerful thing, I think. So thank you for that. And then my last question for you, and if we have any questions from the chat, this would also be a great time to type them out. But what's your number one piece of advice for a member of the community who's thinking about getting involved in advocacy, never done it in the past, but is thinking about taking this plunge? What would you tell them going in, or right as they're sort of making that decision today?
First, do it. I know that's not very helpful, but I think everyone should do advocacy, especially.
I think that is helpful. That is helpful.
I mean, that's a good one. I think that a lot of people may feel like they can't make a difference, or they can't speak for themselves on policy, but you can help out in a lot of other ways. If you know you're scared of public speaking, or you don't want to talk to people directly, you can definitely help facilitate a lot more change than you think you can if you don't want to talk to anyone directly. There are committees that you can be on, like the Capitol Hill Day Committee, where you can give your feedback to ideas and how to make things better, and how to make things function more easily for all patients. And I think that's one of the best things about advocacy, is that you aren't just like pigeonholed to one thing.
And I will piggy right back off what Savannah just said. You're not tied to anything, and there's no amount of time you have to dedicate. There's no amount of anything you have to give. If you have a story to share, if you just want to write it out and submit it, you want to do behind the scenes, you're shy. I mean, I'm not a public speaker by no means, but I could fool you. I've fooled you today. But I'm just, there's nothing that no little amount of thing that doesn't not affect us that can help. So don't think that, oh, I don't have that much to give. 2 minutes to email a senator is more than enough. So it's get on board. And it's, like I said, it's a family. We become a family outside of a family. And when we're able to get in together in person, it's an amazing experience.
Thanks, Jen. And I got this one, Will. And thank you, Will, too. We are very happy at NPF that we have your powers with us in our advocacy team. I will say that. And then Savannah and Jen, thank you for everything you've done, for speaking today. Jen, for moderating a bunch of this conference as well today. And I know we're at 3:40, so I will end it there and just turn it back over to our NPF team. But thank you. And if anyone is interested, please reach out to Will and I. There's a ton of ways you can get involved. Anything, you know, from something small to something big. We want to work with you, and just from our team too, we're thrilled to be here, and really looking forward to a great year and years beyond.
Okay, you guys. So that rounds out our conference. So thank you guys for attending the Healthier Together, Celebrating Our Differences Community Conference. Before we move to the social portion, though, just a few things. The conference was recorded, and that will be available on the NPF website soon. And I'm going to reiterate what I just said is please, 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 please get involved. Like I said, there is nothing too small of amount of things that you guys can't get. And once you get it involved, it's addicting. It really is. It's a good addiction. And then we also will be sending out a survey next week. We want to know what you thought of today's conference. Let us know if you have future ideas for topics. 2 of the topics today, emotional resilience and men and women's health, were actually direct results from feedback from not only myself, but other advocates. And they listen. They truly know. The NPF is amazing at listening to us advocates and knowing that we come from the heart. So definitely take that survey, give your feedback. If there's something that you want to see addressed, get involved and let's make it happen. Let's have it as a topic for our next conference. But we want to go ahead and also thank our sponsors, because we know without them, this would not be possible. So we have, in no specific order, Amgen, Bristol Myers Squibb, Lilly, Pfizer, and UCB. With their support, the NPF can continue to provide conferences in the community. And we know how important it is to bring us together, because this way we know we're not alone. With that being said, finally, next month, our community will gather in Chicago, myself included, and a lot of my other SO family, for our first in-person conference since 2019. The Healthier Together Learning for All Ages Community Conference will take place at the Kimpton Monaco Hotel in Chicago. We have sessions on research updates with dermatologist Dr. Ahmad Chantel Amin, Qigong, and having a professional career with psoriasis. There will also be a youth track to include art therapy and science demonstrations. Former NFL football player and NPF board member Jonathan Scott will be in attendance to share his journey with the disease. Please join us. The registration information is on the NPF website, and we look forward to seeing you there. If you are new to the NPF, please reach out. I am an open book, along with, I know I saw Tammy on here, I know I saw Jim. We are all advocates, and we love just having other people. So please definitely get involved. So without further ado, again, thank you guys for attending today. And before we actually close out the Zoom, we're going to actually open it up for social hour. And you guys can go unmute your microphones. I'm going to turn mine off and I'll let you guys talk, because I want to hear more about those who joined us today. So go ahead and say hello, you guys.
I'm going to stop sharing, and I'd love to see everyone's cameras on so we can actually see all of our lovely community. Tammy, you're quiet. You're waving, but you're not saying a thing.
Oh, I'm just so excited to see all these faces. I'm speechless over getting to see these people in real life next month.
It's a rare event when you're speechless.
Shut up. Hey, Nat, guess what? I got a haircut. Look at that.
I'd have to agree with him, Tammy. If you're speechless, we got problems.
We have some new faces. New is a brand new volunteer with us. Hi, New.
Hi, New.
Welcome, New.
Hi, everyone. Thank you for having me here.
Hello, everybody. It's Jody.
Hi, Jody.
Hey, Jody.
Just
Are you wearing your fringe?
Huh?
Are you wearing your fringe?
I'm going to wear it if I come to Chicago.
Okay, I'll wear some too then.
Hi, Victoria.
Hi, Audrey.
Hey, guys. Oh, hey, Stephen. Are those real eagles?
Those are ones that I took in the past near my house.
Wow.
But they're not standing behind me right now.
Kind of figured that stuff.
I'm actually in Santa Barbara at the house of some of my in-laws. And while I'm talking with you right now, I'm eating crab.
Okay.
Oh.
Because I miscalculated the length of the conference, because originally I was going to do it from the East Coast. And since I'm on the West Coast, I thought it was going to end at noon.
Hi, Nicole.
Hello.
I see Chris is here. Chris is, I think, attended every single conference. Hi, Chris. Can't hear you, buddy.
I said, and they're all wonderful.
Chris?
She's the plant.
Tammy.
Everybody's so quiet today. Nothing to talk about?
Well, it's hard. You don't want to talk over everybody. So, New, if you don't mind saying, since you're new to the group, or is this just your first virtual conference?
Oh, this is my first virtual conference, and I'm new to the group too. I just joined about like a month and a half ago.
Well, welcome.
Welcome to the family.
That's right. You have a new family now.
Yes.
Katie, is that you I see there?
I'm here.
How you doing?
The same.
Hospital, no less.
Yeah, I'm still here. They won't
I
let me.
guess.
But I haven't been interrupted all day, so they must think I'm doing something right. So.
Well, that's good.
No, basically they finally acknowledged that it's coming. The infection invaded my psoriasis, and they've all have started to make a point of actually learning a bit more about the psoriasis, which for which I'm grateful. And helping me to actually treat some of my other spots while I'm here. So I thought that was good news, but it's just getting everybody else on the same page to now get the infection treated so I can get back to treating the whole picture and onto a biologic. So that's all good. Pardon
Good
my
luck.
parents, they don't let me get things wet and I'm feeling gross. So
You're not looking gross.
Not at all. Just
No.
glad you're
No,
here.
look fine.
and that was like the other thing I was grateful for the foundation for, because like this is a readmit for me. I spent the first admit trying to convince the medical community that listen, these spots on my legs that are infected started with psoriasis. And they're like, no, they're ulcers. I'm like, no, it's stemmed from a really bad flare, and actually referring them to stuff at the NPF. I'm like, without all of that information, I would have nothing to stand on with them. And when I came back this time, the same doctors I was dealing with the last time were like, oh, all of that information, how's your psoriasis doing? And started asking some right questions. So I'm like they're starting to pay attention. So
You're an amazing
Oh,
advocate for
kind.
yourself.
well,
Yeah.
it's not just me. I figured there are going to be other people in my position that have psoriasis and wind up here.
Yeah.
And it would be
Yeah.
helpful for them to, that might not quite be so assertive, to speak up and say to these doctors, hey, wait a minute. Have somebody on their side too that have these doctors know something.
Right.
Absolutely.
No, Katie, first of all, good to meet you. I'll say my version of this story is I have hemophilia, which is, a lifelong condition. And when I was a child, this was before I could advocate for myself. My parents took care of this one. I went into the ER with a bleeding event. And before they gave me medication for that, the doctor wanted to test if I still had hemophilia. And my parents blew a gasket. They're like, no, A, it's a lifelong condition. B, the tests you want to do don't make any sense because he already has factor in his system. So it really is, you think people are so educated, so knowledgeable, but they have very specific areas of expertise,
Yeah, exactly. And that was kind of what I was running into. The biggest issue is with the guy that was with the infectious diseases, who is treating the bacteria that has gotten into this. And he's a really, really smart infectious diseases guy, just knew nothing about psoriasis. And this time around, like I said, having talked to him last week, I actually got him on board to have him talk to my dermatologist also. And this time he walked in, saw me and said, oh, who did you inherit psoriasis from? And I'm like, oh, we're finally in the same book. So I know not everybody inherited it from somebody, but at least now he's paying attention. So, and I feel grateful for the psoriasis community also, because I feel a lot of support from all of you out there too, paying attention to my updates and all.
Well, think about it, Katie, before the day, and even social media as well, right? Because before the day of social media, maybe only a handful of us would know about what you've been going through. And, just look, good for you. Like James said, you being a good advocate for yourself. And at times that's what it takes, because, sometimes you just have to be.
Yeah. But as I said, I don't feel like it's just for me. I feel like there are some people out there that just don't feel like they have that voice. And I'm like, this is what I do when I'm not here. So, it's getting them to focus on how my disease is working. The person that feels like they don't have that voice, it's getting them heard too.
Yeah.
So I actually had my overnight nurse say to me that she has psoriasis, and she's never told anybody at work because it's only on her scalp. She was embarrassed about it. So I'm like, that's somebody who works here.
Wow.
Nice hat, Jim.
Thanks. Couldn't let you walk alone.
I know, brother. Thanks.
You know, Katie, I ran into the same problems when I ended up with that malignant otitis in my ear a few years ago when I was on the cyclosporin. I went to the ER 3 times. First, they gave me antibiotics. The next time they gave me IV antibiotics and told me to quit putting Q-tips in my ears. I'm like, I have psoriasis in my ears. Can I think of anything worse than having a scale stuck where I can't get it? I don't put things in my ears because that's just nasty, right?
Right.
So the last time, my whole face swelled up. This is 3 days in a row. And we're on the way to the ER. And I said to my husband, I don't even want to go because you know what? They're going to let me die in a parking lot. Something is wrong with me and they're going to let me die in the parking lot of an ear infection. Well, it ended up I had malignant otitis. That infection had gone down into my jaw. And still, the doctor that's admitting me is telling me, well, you have this yeast infection in your ear. And I'm like, I don't have a yeast infection in my ear. It's psoriasis. And he's like, oh, no, that's a yeast infection. I'm like, okay, dude, you know what? Whatever you say, just do something for the love of all that's holy, you know? So they finally admitted me and the hospitalist came in. He said, you know what happened? And I said, yes, I do. The cyclosporin, I was at the end of it. I got an ear infection. Nobody paid any attention to it. And it turned into this big thing. And he said, I said, and I told my husband, this hospital is going to let me die in the parking lot. And he said, you know, I'm not really sure if you know how close you were to dying.
Wow.
And I was like, who dies from an ear infection? He said, you're lucky that infection went into your jaw instead of your brain. And I was like, holy cow. They really were going to let me die in the emergency room. And they're sending me home with prescriptions for the yeast infection in my ears.
Oh.
Like, okay, whatever.
Wait, they sent you home with antibiotics for a yeast infection?
No, they told me that my psoriasis in my ear was a yeast infection. By the time they admitted me to the hospital, they had given me 3 different antibiotics, and I had a Pseudomonas aeruginosa, whatever, that needed very specific antibiotics, and every antibiotic you give makes it more resistant to the next one. I was in the hospital for 4 days, and it took them 10 antibiotics to find one that worked for me. I mean, it was miserable, and I told everybody, I was like, I've been telling you, I have psoriasis. I'm on cyclosporin because that's what they drilled into me. They were like, you're on cyclosporin. So you tell everybody, if you get any kind of infection, make sure you tell them you're on cyclosporin. And everybody's like, well, we don't know what that is. And I'm like, aren't you the emergency room?
Yeah.
I mean, isn't that kind of basic? But apparently not. And, you know, I mean, it's me. So I'm just making stuff up.
Well, there are days I definitely felt like that, Tammy. Like I'm making stuff up anyway.
Yeah, I'm like, yeah, because that's where you want to be, right? You want to be sitting in there, right? Yeah.
Right.
Makes you happy, right?
Absolutely. Favorite place to sit.
Mm-hmm.
Yeah. It's sad that I know these people by their first name basis.
So who's all going to Chicago next month?
I'm a maybe.
I'm back and forth.
I'm team maybe as well.
I do hope everybody can make it. It's been the first time in a long time. And new, if you can, particularly since you said you're new, I don't know anybody who's attended a conference that has ever regretted it. I know for myself, I think other people will say it. It was a life-changing experience, and
Yes.
for anybody,
Yeah,
100%.
Sorry. I couldn't attend. I will be in Chicago, but I have my annual training with Regulate at that time, so I couldn't go.
Okay. Well, just so long as everybody knows they're welcome, and we'll have others.
Yes.
Well, listen, guys, I'm going to sign off. So peace and love to everybody. Great seeing you.
Bye,
Jen,
Matt.
thanks for hosting today. God bless. Everybody at the NPF, thank you for all the work you do.
Everyone have a great day.
You too.
Thank you.
Thanks for coming,
Take
guys.
care.
Thank you, guys. See you next
Bye.
time.
Bye.
Love y'all.
Aw.